Dr. Vijay Kumar Trehan. He's the chairman of cardiology, Maharaja Agrasen Hospital, Delhi. He is a former director, professor, and HOD Department of Cardiology, JB Pant Hospital, Delhi. He is having 35 plus years of experience in cardiology and interventional cardiology as well. Trained more than 200 cardiologists practicing in India and abroad. A renowned interventional cardiologist with extensive experience in complex coronary and structural heart intervention. Recognized for excellence in advanced catheter-based cardiac procedures and cardiology training. And he has a lot of expertise in specifically in intervention. So without taking much time, I would like to hand over the session to Dr. Vijay Trehan. Yes, sir, over to you.
Good morning and welcome to all of you. I think there was a lot of discussion about science and a lot of data. And after this we have fun. This is a fun time because there were the slides with you were trying to dig out, looking at the coefficients on the left or the right side and see whether aspirin is helping or not. And finally what we deduced was that this so-called R field called as medical science, very little science. What we were talking about the science, so much of data. In your day-to-day practice, this is this much of art. All the time we are artists. We are supposed to perform according to the need of the patient, and that's what was the conclusion at the end. That if you want to give aspirin, hold on aspirin, give for a short duration, or you want to give for long duration, individualize the patient. So here we will talk about something which is not science, something which is anecdotes, because there are no studies on dissections and perforations and evulsions. So, friends, we all know that whatever goes inside can produce dissection, and we know that the dissection can be induced by a wire or a balloon or maybe a rotational atherectomy and so on. Whatever goes inside the coronary artery and tries to handle the lesion can produce dissection. But much before you enter the coronary artery, you can just create a dissection, especially if there is an osteoproximal disease and you're trying to hook with a guiding catheter. What you get is, you get a dissection like this. You see, there was some disease, and now what you see is a spiral dissection. And worse, if you inject something which was supposed to be handled very, very carefully in the form of a guiding with osteoproximal disease, you didn't bother about it. You injected it further and you worsened the dissection. Look at the dissection has gone into the PDPLB. And the worst is if you wedge inject, and that too with a guiding catheter which is aggressively cannulating the coronary arteries. Typically, if you have employed variety of catheters and if you try to wedge inject, this is what you are going to get. And this may not stop there. This may go up into the arch. If it goes down, you may try level best. What you try to put a stent in the coronary artery, you will end up only in a star-like result, hardly any branches. And the same dissection, once it goes into the carotid, can produce stroke. If it goes down, it can produce AR. So, very, very difficult to treat. If you get into a situation like this, often you'll have to call a surgeon. So, most important thing is prevention. And by prevention, what I mean is prevent aggressive intubation of the guiding, especially those guiding which are aggressively like LGML, VODA, and your employed variety of catheters. Nowadays we have long sheaths. Nowadays we have guide extensions. So you can have simple guide through a long sheath, wire the vessel, and advance a guide extension. Guide extension is supposed to be thinner or smaller lumen than the guiding catheter, and this is how you can prevent buying a dissection or worsening a dissection. What is important is, especially in the right coronary artery, you try to be coaxial, because most of the time we get into the right coronary artery in the LAO view and work in the right coronary artery in the LAO view. But let me tell you, LAO view will just not tell you whether the tip of the guiding catheter is coaxial or not. So always try to be in RA view to see whether your guiding catheter is coaxial or not. A lot of time people will take guiding catheter which have side holes, or you try to cut side holes in catheters with your own needles. But side holes is almost never a guarantee to prevent any kind of a dissection. So I have a hall of about 150 people here. Do you think can a resident perforate an artery without doing a PCI? Anybody? Residents are supposed to either wash or do simple angiograms. They are not supposed to walk into the coronary arteries. Anybody? Say yes or no? Okay, look at this. Resident performing an angiogram, and look at, there is a stain which is building up far away. Far away. And he doesn't bother about it, continues to inject, and the stain builds up. So, even a resident can produce remote perforation by not being careful that your diagnostic catheter is wedging. So, sometime, like there is some perforation there near the PD. Can anybody see any perforation in the PD? Or a branch of PD? Not really. So what really happens in this situation, you try to take the guiding little more in and try to inject with some more force. This is what was done. Now you start seeing it. Can you see it? Clearly some stain is building up there. And the operator is not very happy. He wants to see an orthogonal view. He goes to the RA view and does the same thing. Now see what is happening. See, this is one of the biggest reasons to get into distal dissections and perforations. That there is something, you're not seeing it well, you want to see it better, you take the guiding little more in, and you are not bothering whether your guide tip is wedged, your pressure is ventricularized or not. You just push in the guiding catheter and inject with little more force, and that is what you get. You start seeing more, but I think you have worsened the patient. Here is a very experienced interventional cardiologist, and he wanted to do a retrograde through a vein graft and see what is happening. He's connected a power injector and the vein graft on the top. On the lower one, the lower catheter is in the native artery. The vein graft has been evulsed by an experienced operator. Now this experienced operator is very experienced. It tries to coil embolize. It has coil embolized it, but continues to do a power injection. So despite having coils there, you see they are blown up. So moot point is, while you are handling such cases, never ever wedge inject. This is a very experienced operator, is doing a retrograde RCA CTO, is very easily done, retrograde RCA CTO, an excellent result, only to see that the feeder artery has created the feeder, that was the left coronary artery, got a dissection by the guiding catheter. And how does the dissection happen is, you see the guiding catheter of the left side is diving in, and the guiding catheter dives in at a time when you try to exteriorize the wire. Let's say RCA was CTO, you took the wire from the left to the septal, you go to the right, it enters the guiding catheter. Now either you pull it out just like this with the help of a snare, or you trap it with a balloon and pull it. Now this is the time when the guiding will try to dive in. So you must know that you should almost never pull a wire which has been exteriorized. You just push the wire from the left, don't pull it. And if you just push it and without pulling from the right side, you'll never get this kind of a misadventure. Anybody knows about NHLBI? I think this is, if you talk about dissection, you should know that NHLBI gave us the classification of dissection. This was some 50 years ago, and we almost never describe NHLBI dissection in the cath lab. But let me just give you a flavor. This is ABCDE. A is just a filling defect within the lumen, and the dye doesn't stay there. More than a filling defect, it could be 1 or 2 lines, is B. This is again a B. It may form a cap, is there. Then, if you have a dye which is outside the lumen, this is C. These people tend to almost always stent. But as far as the scientific indication is concerned, you can leave these dissections, since they were dissection only at the time when you were power injecting, and they will not increase if you leave them. And many of these dissections, if they are left like this, they will heal over a period of time. So this dissection is a spiral dissection. These dissection may heal or may not heal. If a spiral dissection is having a good flow, even they will heal. So till this point in time, general recommendation is that you don't have to treat these dissections with a stent. However, if a dissection E, that means a new filling defect is building up distally, this will rapidly try to close the vessel. So you have to quickly wire it and stent it, as was done in this case. And F is a dissection which, after, let's say, any event, either guiding catheter or a balloon or wire, suddenly decreases the flow, and the vessel tends to just close down there only. You have to show alacrity and quickly wire it and stent it, as was done in this case. So the Guru Mantra of dissection is avoid and avoid. And if you have not been able to avoid and it is something which is flow limiting, immediately stent it. Second Guru Mantra is, if you are in the procedure, never, never, never allow a wire to be lost. Because if a wire is there, then the dissection can always be attacked with the help of a stent. But if you lose a wire and the vessel closes, it may be a big problem. Now, can anybody tell that if you have to perforate an artery, how much you can stretch without perforating? Anybody? Well, the answer is already there. This is that you can stretch the adventitia up to 80% beyond its capacity. That means you can be up to 1.8 times before you perforate the artery. But you will wonder that you almost never take a balloon which is 1.8 times. This is because the balloon which is 1.8 times, the perimeter will be far bigger. So stretching is at the perimeter. Perimeter is 3 times the diameter. So if you have to go up to 1.8 times, your diameter will not be 1.8 times. Your diameter is 1.3 times. So if you are oversized by 30% above the diameter, this is the time when you can perforate the artery. But many times you must have seen the arteries are perforating even when you have not gone oversized. Any reason? Anybody? The principle is the same. You cannot perforate an artery, you cannot tear adventitia unless you have stretched it to 1.8 times. And I told you 1.8 time corresponds to 1.3 times the size of the diameter of the balloon. Still many times the balloon is 1:1 and the artery perforates. Anybody? Okay, now let me just tell you. This is calcium. This part of the vessel wall will not stretch. You try level best, especially in eccentric calcium. So if you take a balloon which is, if you look at the size of the vessel, this balloon is smaller than the size of the vessel. This was the vessel wall which will stretch. Rest of the vessel wall will not stretch. So if you blow up a balloon, this will stretch like this. This is clearly more than 1.8 times. So even a balloon which is sized to the vessel, if you try to blow up the balloon and try to go up at high pressures, especially in a patient who has an eccentric calcium, one wall of the vessel is not going to expand, the other wall is going to expand. This will create perforation. So if you have a recipe like this, you have an eccentric calcification, you should be always be careful that you do not overstretch it. And try to modify this calcium before you want to stretch this rest of the part of the vessel with a balloon. Now commonly we talk about Ellis classification of perforation, and we know one is just a dye which is forming a crater, 2 is a hole through which the dye gets out but doesn't enter the pericardium, 3 is the hole is there and the dye freely enters the pericardium. The last one produces hemodynamic compromise, but even 2 can produce a hemodynamic compromise. So for practical purposes, 2 and 3 have to be treated the same way. It is only the one in the form of a crater which you can leave it. If you have a leak of the dye, whether it is entering the pericardium or not entering the pericardium, you have to seal it. Because the one which is not entering the pericardium right now, it is possible that this will enter the pericardium over a period of time. So the first thing which comes to your mind is prolonged balloon inflation, pericardiocentesis and covered stent. This on one end, and at the other end, you try to perfuse the vessel and try to increase the hemodynamic support. So if you have a perforation which is less than type 3, like in this case, you just do a balloon tamponade, this will heal. But sometime even a type 3 perforation, if you reverse heparin, might heal. But what you can get is, you can get a thrombus there. You can get a thrombus in the coronary arteries, you can get a thrombus in the pericardial sac. Here there is a perforation and the operator reversed heparin and inflated a balloon there. He was able to kind of achieve homeostasis, but the distal flow went down and ultimately the patient arrested. This kind of a perforation can be handled even without a covered stent by just reversal. But generally, if you have a free flowing perforation, what is needed is you need some kind of a covered stent, like it was used in this case, which will just take care of the perforation. Sometimes you put a covered stent and the perforation doesn't heal. The important reason is, like, this is the entry point and this is the exit point, and this is where you are seeing the perforation is getting out. So you put a stent there, the inlet is not sealed. It is possible that there is some gap here from where, or even if you inflate the balloon higher, still the leakage will be coming from above. So what is required is that you might have to seal the inlet part also. Look at this perforation, and one of these covered stents, some of them have different coatings, some are double layer, some are single layer, some are cobalt chromium, other are stainless steel. And if you do not have a covered stent with you, then you can make one with the help of stitching a balloon on it. You can put tegaderm on it, but a free flowing perforation like this will have to be sealed. And nowadays what we see is that if you have a free flowing perforation, don't be free flowing in the cath lab. Just be comfortable. To be comfortable, quickly have an access from the other side, so that you have two guiding catheters. So you have to do so-called ping pong. In the ping pong, this is a perforation. That's the guide. This is a wire there. You just inflate the balloon which was there, which created a perforation. Same balloon. Now, very low pressures. Maybe half an atmosphere is just good enough to stop bleeding. Then you let the vessel breathe out, put the guiding out, then take another guiding catheter. This guiding catheter has to be bigger. Through this you have to deliver the covered stent. Pass a wire, once the wire reaches the balloon, deflate the balloon, pass the wire distally. Now reinflate the balloon again. This will stop the bleeding. Now take a balloon on the second wire through the second guiding catheter. Now let it inflate, and then you can either intubate the guiding catheter or you can intubate the guide extension through it. Whatever has gone in, now you can deflate the balloons. The balloons can go distally, and then you can advance either the guiding or the guide extension over one or two balloons. Once your guide extension is at the site or beyond the lesion, then both the balloons can be taken out, and even the second guiding catheter can be taken out, and then you can take a covered stent to the site and then pull out the guiding catheter or guide extension, and then now you can inflate this covered stent there. Don't be at high pressures, just low pressures. Then, because if you go at high pressures, then this can create another perforation. Just try to open the covered stent. Once it is opened, then take a balloon which is smaller in diameter, smaller in length and bigger in diameter, and blow it up from within. Now this will seal the perforation, and you will not be getting a chaos in the cath lab if you have a ping pong technique, because you have control all the time. So this was a perforation, which is a free flowing perforation. If you see, this is the first guiding. We took a second guiding catheter, then a wire through the second guiding catheter. This enters, you have a guide extension through it which enters the stent. Guide extension is taken deep, and then this perforation is sealed. Can you see a pigtail in the pericardium? No. So if you are proficient with your ping pong technique, it is possible you don't require anything. You didn't require to drain the pericardial sac. However, subsequently we had to put a pericardial drain because there was additional perforation distally. Nowadays we are going to get a ringer balloon. This balloon is like this, which is hollow from inside. If you inflate a balloon across the perforation, this will work like a temporary covered stent. And if you see, this is site of perforation in inflated air, and the blood will keep flowing through it. So this was a perforation and a balloon is inflated, the blood is still flowing distal to it. Then you deflate the balloon after maybe 10-15 minutes and the hemostasis is achieved. No covered stent was put. Here if you see, there are multiple branches coming from the RCA distally. So there is a perforation here. If you put a covered stent, all the branches will go off. So what was done was, ringer balloon was put there. This worked like a temporary covered stent. All the branches are flowing through it, and finally this balloon is taken out and there is no bleeding there, and you have preservation of all the branches, and there is no covered stent. Now it's fine for a big vessel, but for a distal vessel which could be small, terminal vessel or a collateral, it doesn't have any ischemic potential. You can sacrifice these vessels. And how do you sacrifice these vessels? Is you can either put a balloon there, blow the balloon for some time, this might seal, but more often you can take something inside and seal this. If you look at this perforation, if you just leave it like this, this will not stop. So you'll have to pack the distal vessel. Look at this distal LED perforation. Somebody put a coil into it and see what is happening to the coil. This coil is going into the distal LED, and then it goes where? Well, we don't know. I think it has walked somewhere out of the vessel, and in this case it was shot into the pericardial space. So to prevent a coil from getting out of the artery without your control, I think nowadays we have coils which you can put with full control of yours. they are detachable coils. And these detachable coils you can detach either with the help of a mechanical system like this, ball and socket, or you can have electrolytic system. You can just give 9-volt current from outside and the solder gets melted out. Or different methods are there, but then these detachable coils are costlier. You have to pay for it, generally 5 to 10 times the cost. But a simpler alternative which I use is, like in this case, this was a bleeder. So you enter into this bleeder, take a microcatheter there, and take second guiding catheter there. Through the second guiding catheter, this is a microcatheter in the bleeder, then through, and there is a microcatheter there. Then you take a second guiding catheter, through this you take a balloon there. You inflate a balloon there, this balloon will fix the microcatheter and will also stop any blood getting to the feeder. Now you can deliver coil through it, which will deliver. So as you have fixed the microcatheter, it is a precise delivery of the coil there. This can be done in most of the cases. Now sometime you are trying to deliver a coil, like you tried to deliver a coil in this case. And you see that there is a clear cut bleed, you have a microcatheter in the bleeder, and you are just set to deliver a coil there, and the coil goes, and finally you find that the coil is not able to get out of the microcatheter. This sometimes can happen, especially if you are reusing microcatheter. So you should have an alternative. Alternative is you can inject liquid through it. Liquid is thrombin, cyanocrylate, and you have different forms of cyanocrylate. But the one Fevikwik is available everywhere. 5 rupees. You can have a Fevikwik. It is almost always sterile. You can put it in the coronary artery and just forget. Or you can take solid or gel form injections. And then sometime you can just take fat, which you can harvest from the groin. Or you can take PVA particles. For bigger particles you need. Sometimes even threads, suture. You can cut the suture and put in the microcatheter and push it there. You can have a biological material, you can take a fat from the tummy or you can take fat from the groin. You can just tease out a fat from here. This big fat will not go through the microcatheter, so you have to tease out with the help of a needle and this. This will become small particles like this, put them in the syringe and you can transfer it to the microcatheter. If it is fat, it will float. If it is not fat, it will not float. Doesn't matter, even if it is not floating, you can push with the help of a wire. This will go inside and then if you push it, you see it, on pushing it will get out of the tip. And how does it get out of the tip of the microcatheter? It is like this. See it goes like this. So you can tease this fat and push it, and sometimes you can just push blood out of it and the blood will go out like this. So these are very handy things. Fat and blood can be pushed out of tip of the microcatheter, and if you take the tip of the microcatheter right into the vessel, like in this case, and the fat was injected and the bleeding stopped. So now what to do in this case? Free flowing perforation. Anybody? Anybody? Raise hands. What to do? Immediately? Covered stent? PVA particles? Fat? What? Let me tell you, check the pericardium, there is no fluid. So whenever you have a free flowing perforation, it is possible. See, if the vessel is here, the pericardium up, and the blood goes into the pericardium, you get a pericardial tamponade. But if the vessel is in the interventricular septum, it ruptures into the left or the right ventricle, like it is there in this case. So you have a free flowing perforation and you don't need any covered stent. Also, if the vessel is perforated into a vein, adjoining vein, like it happened in this case, this is a great cardiac vein there. The perforation is into the great cardiac vein. It might look horrifying, but the pericardial is empty. So you don't necessarily need to do anything in this case. So remember, if there is a free flowing perforation and rapid clearance of contrast, you see that contrast is clearing rapidly or not? This is clearing rapidly. If the contrast is clearing rapidly and the patient is stable, like this case, just be calm. This is going to one of the cavities. Don't get bothered. However, if the contrast is not clearing fast, it is building up, it is started to show pericardium. So this contrast which is not building up rapidly, you need a rapid action. In the rapid action is generally in the form of calling from both the sides, as was done in this case. Finally, if there is a persistence of stain, it should never be complacent, because of persistence of stain can be either increasing or decreasing perforation. In fact, you should always believe that a persistence of stain is trying to build up. So no patient should leave the cath lab if there is a persistence of stain. and you should handle it with whatever armamentarium you have it. And finally, if you want to leave the cath lab, all of you should have something like this definitely. This is a sono contrast. What is required is just inject intravenously. If things go and stay within the heart, fine, absolutely no problem. You see that pericardium is empty, the contrast is not entering the pericardium. See that? Everything is just within the heart, not entering the pericardium. If nothing is entering the pericardium, this is the time you can just stop, go out, go to your home. Thank you very much. So ready to take any question? In fact, I asked many questions during the talk itself. So Lord Srinivas wants to ask one.
No, I want to thank you again because sir has a lot of collection and is experienced in managing complications of a lot of other youngsters in the institute too before. That's why I always make it a point for him to, in spite of his all busy schedules, persisted for him to come and take this session. That's why we have to switch this perforation talk from yesterday to today. Thank you, sir. And the way you make slides, animations, also the self-explanatory, and it is very easy for everybody to understand. Thanks again.
Thank you.
Thank you, sir, for this wonderful session. Now it's time to felicitate. I request Dr. Ramachandra to please come on the stage. I request Dr. Ramachandra to felicitate Dr. Vijay Trehan for this wonderful session. Sir, please go into the center so that. Thank you very much, sir. Sir, Srinivas, sir, please, you also please come on the stage. I request Dr. Srinivas to felicitate with the bouquet. Thank you very much, sir. Now I would like to hand over the podium to Dr. Srinivas to further proceedings. Yes, sir, over to you.
Good morning, friends. I think after a very interesting presentation by Dr. Trehan on perforations and dissections, we will now see the guidelines for the session. Actually, that talk, because Sir Kund was not able to come yesterday, we came today. And other important guidelines which are very important for all of us is ACS and STEMI guidelines, which again got recently updated. I'd like to take you briefly is first present about STEMI guidelines, then also come to NSTEMI guidelines, and I'll try to show some case examples in between to make it a little more interesting for all of you. And then one thing which is common is both types of whether STEMI, unstable angina, and STEMI is the initial presentation and the final maintenance of secondary prevention is all common for both. I think that's why it is clubbed both and try to present to you. The most important initial presentation is the diagnosis of it, though ECG helps, and the chest pain history is most important for us to diagnose. Nowadays youngsters tend to take history little less seriously, but it's very important here. 90% of it comes through history taking and spending time with patients, and in which menu it is happening, what are the risk factors for that patient, and what is the pretest possibility. All that also plays a long way in diagnosing the patient right. If you see, it looks, at least when we were students, I think it was very intriguing to me. What is this? In one it works, one therapy works, in one it doesn't work. One is white thrombus, one is red thrombus, all that. But it's gradually now we come to know it's more of this can anytime progress to the others. So because that's how the pathology goes inside. If it's a non-occlusive thrombus, ST depressions. If it's again troponin positive and troponin negative, positive we call it as NSTEMI. Then if it proceeds further, occlusive thrombus, then ST elevations come, and again that is what is a STEMI. I think all of you know this. The STEMI management agenda, initially the guidelines came a long time back, and then we had a pharmacoinvasive approach which is very popular in our country, and we'll also share some of our experiences with that and give you some case examples of each of it. Then previously we used to call one thing which is proven beyond doubt, which all of you I think are now practicing, is the radial axis. Previously we used to think that putting femoral we can do it faster, and radial should not be done early in the acute MI, but that is proven itself that it's decreasing. Very important change which decreased the mortality significantly now is going to radial axis. We are also not worried nowadays in lab once you do a radial procedure. If it is pharmacoinvasive strategy followed also, there is no worry of femoral hematoma, because previously other major problem for pharmacoinvasive strategy was femoral hematomas and problems. I think most of you sitting here are switched over to radial routes in acute MI primary PCA. How many still do femoral route? Can you raise your hands? How many are following radial? I think most of them are radial. That's, I think, the best which has happened. I think the problems of hematomas and are all gone. Though you take a little 2-3 minutes more time, still it is fine. But sometimes it's also, the time factor is also gone nowadays. In fact, I see youngsters, Ramchandra would agree that they are more comfortable doing radial punctures than femoral punctures now, because they're exposed like that, the training pattern is like that. So that is proven beyond doubt, and the death is anyway there, already proven. Complete revascularization is the mantra to go. How to stage it, whether do everything together or not, is again we can discuss. But complete revascularization in a cardiogenic talk-up situation where the patient tends to go into renal failure again, that is has a little class 3 indication now we can discuss. Thrombus aspiration, totally they say it as class 3 because some of the trials showed negative results because of embolization, strokes which are happening. But again it has to be individualized. I can show some case examples where thrombus aspiration really benefited the patient. Then these things are less relevant, we don't use it in our country, still we go with regular IV heparin. Then oxygen inhalation, anyway for the sake of comfort to patient we use it, and it's still indicated. And the tenecteplase and I think half dose lytic therapy is what is very popular, and age old streptokinase is gone. So these are some of the newer indications which came, are lipid lowering therapy again to be given more aggressively, more faster, and then these other things which have changed is time delays to be avoided. They need to do it as early as possible. Minoca, again, there are some entities which are coming up, especially in females, to have different type of no atherosclerotic pathology, but normal coronaries or coronaries with spontaneous dissection. And electrocardiograms, how fast should be done, and all that is depicted in this pictorial diagram. Once the patient's STEMI diagnosis is done, if it is coming to a center where lighting therapy should be given, we should try to do it as soon as possible. And if you can shift this patient to within less than 2 hours to a center where primary PCI can be done, then that is what is recommended. Once he comes to a center where perfusion has to be given, less than 10 minutes, more than that should not be wasted before you start tenecteplase. And then if you are doing a PCI, then we should start the therapy as soon as possible to avoid total delays. Main delay is happening once the patient comes to hospital while discussing finances. This aspect is removed, I think significantly helps. That's how we are able to decrease the door to balloon time we used to call it. Now we call it door to wire time. But here the main delays are happening at the point of education of patient. Patient still thinks it is gas and things like that and doesn't come to hospital on time. That's where the maximum delay is happening. The total ischemic time reduction is what is our aim. So still a lot of education needs to happen the public front for them to come to hospital in time. Then primary PCI is what is done, first medical contract, these are all terms which are becoming less and less relevant. The pharmacoinvasion strategy is the one which is picking up. Some examples, some of our experiences we shared some time back, but I think it's very relevant for us. We want to have a rapid reperfusion and also it should stay longer. The power of a primary PCI is this, it continuously result is sustained compared to lytic therapy where arteries might tend to close. Our aim is to preserve LV function and improve survival. There are a lot of trials which showed that the advantages of primary PCI, which we need not discuss. The real world scenarios is it is very difficult to keep the programs on. How many doctors sitting here run the 24/7 primary PCI programs in your hospitals? Very good, I think more than 50%. And only daytime primaries and nighttime lytic therapy is still popular in some of the hospitals, which is to be avoided if possible. But again, it depends upon each of the places. This is the problems happening even in West, it is not 100%. The problems are of the availability, but once it comes, then you have very good results. But some advances have happened in the lytic therapy too. We have the newer thrombolytics like tenecteplase, and which have better fibrin specificity, and we can give it like a bolus. And the opening rates are also up to 80% compared to streptokinase, which has up to opening rates of 50%. So you need not worry too much if somebody is following tenecteplase in the periphery. Give something rather than missing out. The other advantage is drip and shift, giving that therapy and shifting these patients on time. So there are some of the newer things happening in the primary PCI which we'll discuss more. This is the guidelines now which say how to shift these patients. This is what I was telling, that our experience of some patient data which we published and presented in the STEMI book too. These are standard inclusion criteria, standard exclusion criteria. We were giving tenecteplase and then shifting these patients to advanced centers. We have very good experiences like this. Patients with ST elevations, once a lytic therapy is given, then with ST elevations given immediately patients ST is normalized, and then the patient used to be shifted to a hospital. See, this is sort of bradycardia, hypotension, deep ST depressions with hypotension. Then STKs were not given because of hypotension. Then once we give tenecteplase, these patients immediately improve and then get shifted later. Sometimes it happens in corporate hospitals too, where because of various reasons we are not able to give, then lytic therapy is also given. We collected some data. What we came out in this could avoid unnecessary stenting in some patients too, because by the time you took the patients to cath lab after 2-3 days, many of them had recanalized vessels. This is not to say that primary PCI is not good, but some occasional patient who are very young and already thrombus burden is more, you might get away without using stent. That's what we suggested. But some of these patients could die in the process, especially the cardiogenic shock. In QRBV patients, you should be very cautious in talking to the patients. So this study concluded saying that tenecteplase can be safely given in periphery and peripheral setups also, where you don't have full running facilities of ICU. And then once he's shifted here, some of the patients revascularized even without stents. So that's the message of that study, and it's very encouraging to note. The recent guidelines again mentioned that this what I have told before, but one thing which is changed is door to wire time rather than door to balloon time. And if it's first 24 hours, anyway, it becomes a class 1 indication. If it is later also, if the patient has ongoing pain, you would like to consider. Then that's how early prevention stages, stenting is a choice. If the patient comes late, very late, asymptomatically, then that's where it's still a class 3 indication. But I would say in India, still many of these patients still get an angiograms and probably revascularize too, if there's a chance to do it. We see how the angiogram looks in the after the MI, and the perfusion patterns and the myocardial thickness preservation and echo is generally taken as a parameters for us to assess before revasculation. If it is too thin a myocardium, fully LV dysfunction, scarred, those are things which may not be beneficial. But always try to give benefit of revasculation to patients. Even if 10-15% improvement of LV function happens, still recommend revasculation. The infarct-related artery strategy is, there is no doubt. Anyway, we have to do a class 1 indication. Which of the techniques, I said again, radial route is preferred. And a non-infarct related artery, there could be some discussion. If you have doubts, we could clear. But generally, the policy, unless it is too critical or bigger vessel like LAD, we want to stage the non-infarcted related artery and generally do pre-discharge maybe after 72 hours or so. Antiplatelet therapy, we mentioned again ticagrelor and prasugrel are things of choice. Clopidogrel, though it is very popular, is not recommended, are supposed to be given only if you can't give the above two drugs. GP2B3 receptor blockers are becoming less and less popular because we have very potent antiplatelet drugs. And cangrelor, I think how many of you are being exposed to cangrelor here? This again a newer IV cangrelor therapy is become available in India. That is because if you have very short time, where in single hospital setups where there is not much of delay in emergency presentation to taking up to cath lab, and the entire procedures are done within half an hour. That's where I think subset where it could be useful. Or patients presenting in shock, where you're intubated, where patients cannot take orally. Those are subsets I think we used cangrelor even in our hospitals too. Then regarding the anticoagulation, all that things need not be bothered too much, but unfractionated heparin we still continue to use. Aspirin, clopidogrel, prasugrel, and the GP2B blockers I have already told. Then non-infarct vessel, when you are doing it, we can have some discussion. Some of the trials showed plus and minus. I don't want to go into controversy. Aspiration thrombectomy, though it is said as class 3, but I would like to again mention to you that we have to individualize each patient. And if a patient has large thrombus burden, this happens when the patient presents little late. The patient's window period is about 12 to 24 hours. That's where I think thrombus burden is more, and we might use thrombectomy even in such patients occasionally. So individualized therapy is what is to be recommended, not as a blanket therapy, which was there before. Then CRISP-AMI trial is another trial which did with Manish and Duke University, where the usage of IABP was tested with anterior MI. We were leading recruiters there. Though we could do the procedure comfortably, but again, it did not cause outcome differences. So that was the usage of IABP is very popular in periphery. But you want to save some time and get some pressures and be comfortable with the procedure, it can be done, but not to be done as a routine process. Then decision making of STEMI cases, that's where I show, happens because the time of presentation, anatomy of the patient, our aim is for complete revascularization. Then culprit vessel identification, it is not for you. I think you're all comfortable in identifying which vessel involved, but sometimes there could be some confusion. Like this happened recently. 60-year-old ophthalmologist came from periphery, presenting to us his father-in-law, son-in-law himself as a cardiologist. He was sent actually for LCX OM bifurcation PCI to us. But if you see this, the ECG had some changes which are slightly confusing, whether it is anterior or infralateral. So sometimes you might use your discretion to decide what it is. So actually he was sent the troponin positive with a revascularization for LCX. That is a bifurcation lesion. I don't know how, can you decrease the lights little? Then, but here, but echo showed apical hypokinesia and then probably LAD lesion as a subtle lesions. But if you see it carefully in multiple views, then the RCA was okay. Then see this RWMS apex was there, the echo. That's where we got doubt. Then when you are concentrating and looking, sometimes you could find some surprises like this. There is a lesion in the LAD2. See that eccentric ulcerated lesion. So, and if that is seen sometimes very clearly in some views. So correlation of echo and ECG changes along with what is there in angio is also becomes important in doing what is right to the patient. And we did once that LAD process, then patient's pain decreased and hemodynamics improved. And because LCX ramus also looked important, the doctor was insisting that also to be done the same sitting. We did LCX ramus also. Then finally patient did well. So sometimes decision making could be little tricky. Analyze and correlate all the data together, especially in the era of the multi-vessel PCIs now, patients coming with multiple vascular disease, it becomes important compared to only single vessel disease presentation. This is what I mentioned, OM, though we would have preferred avoided, but the doctors were persisting, we did that also in the same sitting. Otherwise we would have done it pre-discharge. And try to keep the procedure simple, avoiding too complicated techniques in acute MI, and try to follow a single provisional stent strategy there, and that's how the patient improved, and immediately the revascularization LV function also preserved. Another some of the times what we find commonly is 31-year-old gentleman coming to ER and he arrested there, and that is the ECG. Then we shocked, and the anterior ST elevation scan were there. We rushed immediately to cath lab. This is how the teamwork helps. I think one of our colleague was putting IABP, and we checked. Then that's a thrombus laden LED there. And here there's no point saying that class 3 thrombectomy you should not use it, because it's all filled with thrombus. So see that all the filling defects. Can the lights be dimmed further? They will be able to see the angels better, these lights. So this the sort of thrombus appearance. I don't think that it is class 3, you won't like to use thrombectomy. At the same time, I would caution, while doing that, you should avoid getting thrombus into the LCX, which could lead into trouble. So that's where we did thrombectomy, and then runs of thrombectomy, then sometimes artery opens and it could collapse back again. It's improved here without clot, and see that everything improved. So we did not do stenting at all. There it's all open. So lot of thrombus burdens, and this is where critical care support also becomes important. Immediately, not only the procedure, immediate post-procedure follow-up is important. Patient had pulmonary edema and the chest X-ray. Seeing this, I felt confident and patient will improve. And nowadays, we call so-called hospital managers in the night. The patient did not pay a single paisa till then. But once I saw the ECG, I reassured them, no problem, he will improve. And finally, as expected, patient did rapid improvements, and day 3 was out, and he comes for follow-up. This brings back some story to you, because all of us, it could happen. At that particular point of time, we didn't know who was he. We did everything thinking positively, because patient gave shock and was then. And this patient did deposit later on, deposited. Most of them do it. And after recovery, everything, he came with a surprise to me, saying that he wants my picture or photograph. And I'm telling the real story. I said, you don't need it. Why? He said, I have a cinema theater nearby. Would like to put it in our theater, patient was telling. So sometimes such sort of high net worth individuals also may be lost, because in acute MI we don't know. So try to do what is good, and then everything will fall in place. I said, do you need not put my photograph? You can put hospital, they will be happy, I said. So such sort of good experiences will help us and make us the profession very rewarding. Sometimes this another types of patients, when on and off presentations, like ST elevations here, and see this, could have a LED lesion, could also have, see the tight lesion in the LED, straightforward, but he also has a RCA lesion, and the direct stenting was done for LED. So this sort of things is more commonly done. Immediately LEDs was stented, ECG is improved. Later on, after 2 days, we bring him for the assessment of FFR to OM. FFR was negative, so we didn't do anything to that OM. And then RCA, again a tight lesion. Then we started doing the procedure. And why it is not important also not to address everything immediately unless it's critical is an example for this. Though it looked very innocuous, smaller lesion, but it was very calcific. It took quite a long time. And then probably such sort of things during acute MI could create trouble and ripples to you. That's why it's preferable to avoid unless it is absolutely essential to do the other vessel in the same sitting. Those are the messages I want to give by showing these case examples. Each of it has a message which I am trying to get it to you. The final result was good, and then the patient did well and follow. So that sort of thing, presentations are also common in our presentations. Another patient of cardiac shock post bypass, for sake of time, I would avoid all this, but grafts also sometimes could lead to present with acute MI. That's what is the message I would like to give. And the grafts also becomes important to revascularize them at time, and very tight lesions. Then though we recommend to use filters and all that in emergency situations, we could avoid doing it and do a good job. I think with this, the STEMI part of the thing I thought I will cover, and end up with showing this one case of where we complex chip type of case, which I will present later. But see this, how this Impella small device is functioning, I wanted to demonstrate in vivo, in vitro, outside. See this Impella, this thing goes into left ventricle, gets blood into aorta, and where aortic valve is here, see how super it functions. That's how it's made so expensive. Still it is very expensive, but you can increase the flow rates and you can control the output. In spite of patient's heart stopping, still you are able to do good procedures in cardiac shock with the availability of such devices. 83-year-old gentleman comes late to the hospital LV dysfunction started, that sort of approach. Previously you would say send to surgery. Our surgeon would be uncomfortable, will be cribbing at you for sending such high-risk patients. But with the help, the surgeon didn't want to operate. We discussed with the patient with the help of impeller support. We revascularized everything. For the sake of time, I've edited here. Then finally patient had good result initially. Then we also did OCT in that setting, documented that LCX and left main areas were good, and that's how the patient did well in the follow-up. I always believe in life, you do start with good intentions, and God will help and everything fall in place. And one thing we need to analyze in cath lab is when there's a problem, try to take help and then analyze what is it and try to get good results to these patients. I think these are the various things I've shown. Some of the things, how it was different compared to what it was. The primary PCI invasive strategy, we now call it door to wire. Radial access is the preferred access. Thrombectomy, though it is class 3, individualized, I showed you case example. Antiplatelet drugs, newer drugs are preferred. Single vessel disease, primary PCI, and sometimes stent only if required. If thrombus is cleared, we may avoid it. And then multivessel disease, probably stage it. And that's how I think we offer therapy. With this, I'll stop. Thank you again for patient hearing. Any questions or comment on the primary PCI? Many of you must be having experiences and of dealing with acute MI patients. I think I'll be happy to take any questions on it. If you don't, if you're experts, then I would like to play that Kahoot quiz what we created for you people. You can meanwhile connect that. Any questions or comments you people want, you can ask freely. And then we'll also, just for sake of fun, I've created that, because if you are asking us to directly answer or ask, a lot of inhibitions in our country, unlike West. Ramchandra, we had recently one MBBS doctor from abroad, came just for what you call the clerkships or something. And in cath lab, she came to see, she was bombarding us with questions so much. So that is the nature of students who come from abroad. But we, though our people know everything, but there's a lot of inhibition in exchanging ideas, thoughts or questions. So how to bring it out, we were thinking. So we created this Kahoot. I think they will be happy because there is no individual direct exposure or contact in this. The only thing is you need to get that Kahoot app onto your phones and get that scan. Once the barcode comes, just scan it through your phones. Then you get it to you and you have to feed that number. Then you will be answering those questions.
Hello.
For fun time, before we break, we can have this Kahoot quiz.
Hello. Am I audible, sir?
Yeah, any question you want to ask?
Morning, sir.
Yes, sir. Yes. One question.
Where?
This side.
Yeah, please. Go ahead.
Sir, in the last case, you presented DVD with side branch disease, where LAD, proximal LAD lesion, mid RCA lesion, and OM, I think, major OM. So you did FFR in that OM part. So it could be diabetic patients, sir?
Yeah, ready? Yeah. Okay, I'll take that question, then we'll go into it. That is, patients was diabetic or not, I don't remember exactly, but it doesn't really matter there, no? Because patient, OFR is negative, anyway you won't do it, even if
because, sir, LCX has low myocardium burden, so FFR could be negative if there is a microvascular dysfunction.
Yeah, you
so we could do NHPR.
Yeah.
Hello.
That way, there's various methods of assessment. There's one Kahoot question on that also. I'll come. Okay. But generally, when the patient is taken to cath lab, what is immediately solvable, we might have done like that. Suppose we have discharged the patient, our patient is coming for follow-up, we would take that approach, I would say. But anyway, pre-discharge, we were trying to do it, so we did it.
Yes,
so,
sir.
But depends upon, many of the times the lesions look important, but myocardial score is less, so it will come negative in FFR. That
Yes, sir,
also
definitely.
I think his question is basically whether FFR is reliable in acute MI situation. Yes, it is reliable. Nowadays there have been papers which say that non-infarcted artery, the FFR is reliable even in acute MI.
Achha, that was his question.
No,
right?
sir.
That is also correct.
The exact question is, we could use NHFR first if it land up between 0.88 to 0.93 and FFR is falsely positive, then it could be microvascular dysfunction. So we could stand that segment.
Okay, this anyway, that time what I wanted to highlight was basically you can use it, and if it comes negative you can leave it. and you need not always be doing everything in the same sitting. That's why I say some cases have accumulated to demonstrate such principles, and one of it was that. Okay?
Okay, thank you, sir.
Now let us get this. Audio should be there. What happened yesterday? Without audio, it looks. कल तो play हो रहा था. देख कल तो play हो रहा था. Start play. Start coming no. Anyway, there's some problem. It was supposed to come with audio. It's not coming. They say. How many doctors have logged in already? I think 35. I think more of you can get through it. Huh? Did you enter the game pin? Can you start? I think more doctors are joining in, and whoever does it faster, whoever does it correctly, and more points to given to it, and finally 1, 2, 3 will get some prizes. That's what Lupin told. Yeah. Shall we start? How many of you logged in already? 78. Still going on. We'll give some time. Okay. You have time? We'll just give first time they're logging in. It's important for most of them to log in. 87. Because interaction is not happening, I thought this way at least there is some interaction. Okay then. I think the good number of logged in 94, 95. We'll start.
नहीं we are waiting for the people to join in.
You can start. Then we try to make it very simple initially for you to encourage. This is very basic question to be done by even MBBS doctors. Okay? But the swiftness, the correctness of what you answer also becomes important. Sound is not coming. Anyway, if it is done correctly, I think most of them will answer correctly. This is the cardiology session, they will be right. Go to next. What is this indicative of? Why it cut over? It's coming okay. So it is indicative of typical angina, atypical angina, muscular non-anginal pain, or teen syndrome. Answers are still going on. I think most of them, as perfect, it's Levine sign. That's the classical description of angina which was initially given, and all of you answered it correctly. I think perfect. The sound comes, it will be more interactive and interesting, but somehow it is not coming. But it is. We'll now go into a little more difficult questions, hopefully. Next. True or false, very simple to answer. Abort test is, which test is most sensitive? You are telling this, and some of them wanted nuclear scans. So whether it is correct, which is most sensitive to detect CAD? How many of you think it is correct? How many of you think it is false? Let us see. So 1/3 group thinks that it is useless. Significant number thinks it is nuclear scan is correct. We have to detect it. I think sensitivity wise, let us give some respect to it, and it's supposed to be good, and many of them agree for it. Next. Here you have to type the answer. Gold standard test to diagnose CAD. What is that osteal here? Simple to type it. Most of it you can easily type the answer. Through the various things which is suggesting, I think angio is the correct answer. Most of them typed as CAG. That's okay. I think next. I think that's done. Another quiz. What is the most probable diagnosis for this? ECG, what are the findings it is showing, and what investigation will do to confirm the diagnosis? So what is the most probable diagnosis of that ECG? HOCM. I think sometimes we get confused with those deep T inversions. I think with the echo is diagnostic of it, and most of them have answered it correctly. Next, I think this basic quiz, which very basics is done. Can we see the results? If participation is important, don't get us wrong. But only thing is, for fun's sake, who has done it faster? Balwinder. So please come over and receive a prize. Request Ramchandra to present to him a shawl and a pen. Second, all of you answered it right, but who has done it faster, it gets more number of points. That's number 2. क्या हुआ? उसमें second, third prize नहीं देना है. He decided to give only one prize. It looks. What is this number 2? We thought we would give it to 2-3 people. No? You are not getting the name of second doctor. So it's not written. Huh? Unless you type your name there or your phone is on your name, it doesn't take, I think. Who is DC? You? How to believe you, man? You're DC? Okay. He has typed it in the phone. Congratulations. No, it's only fun you're saying. Give him prize. What is who is the DOC doc? All are doctors here, man. But I request you to type your name, so it is more fun, you see. Balwinder did it right. Now, we'll go to another quiz for 5 minutes on STEMI interventions, okay? So can you scan this code and all of you become active on it? you're supposed to enter 3347771 as a pin. Then you reach there. Time of name comes only, we will give prize card. Ramchandra, what do you say? DC, DOC doesn't look good. You should type your names, man. That much if you take effort, then only we will give you prize. Please type your names. Okay, how many logged in? 100. Okay, good. So shall we start? Okay. Young MI with thrombus, decision to stent or not to stent, decided by. What is happening? What investigation? IVUS, OCT, angio, FFR. If you answer after the time is over also, I think it doesn't take. The correct answer is OCT. If we plaque erosion, then not much of plaque inside, we don't stent. If it is a plaque inside with rupture dissected plaque, then we would stent it. That's how we decide whether to stent it or not. So though angio indirectly gives us an idea, but decision is done finally An OCT, some of you thought angio, that's also was earlier ways for doing it, but you can't be definite on angio alone whether to leave it or so entire thrombus is cleared, sometimes you may avoid stenting. That's what to follow it. But more definite way is to decide by using OCT. That's why many people answered angio also as a second choice. It's okay, but final correct answer is OCT. That's what most of the people answered. Next. Recent STEMI with multivessel disease making by FFR versus angio guidance. Which one recent one of the trial conducted on this subgroup? Which was the trial? Fruit trial, flower trial, beans trial, FAME trial. Correct, I think. Some of them has mentioned it has beans also. 34, I don't know what it is. But basically the flower trial which showed that could be useful. Next. Thrombectomy in primary PCI is a class 3 indication as per latest guidelines. True or false? False समझे. 12 people have answered it is false. It's highlighted in the talk also so much, though it is come, but I feel, you really feel it is false, I think, because guidelines are wrong, he means. So because thrombectomy is still indicated in some patients, that's how the answer is, still some of 12 of them still said it is false. So in principle, we also feel it is false, but guidelines said it is true. So 94 of them answered it right. I purposefully kept it little easier ones because you shouldn't, otherwise difficult you won't, you will refuse to participate only. That's why I kept it. Next. Most important, which can further to improve outcomes in primary PCI. Which are the things which are most important out of which what you said? Answers are there. There will be variable responses to this, I feel. %57% of them feel. I said patient education presentation time delay is again still the most important. Door to balloon, door to whichever we are trying to do our best, but still the maximum delay is happening for the patient presentation point of view. I think that's why we kept that as a correct answer. I think most of them answered as door to balloon time, which we generally thought as a marker, and now we call it as door to wire time. That's why door to balloon time is no more said. The patient education presentation time delay is what matters most because the patient is coming late. The hospital, however short you do door to balloon, still it is not doing much. So actually total ischemic time is what is most important. Here the maximum thing of that is taken by presentation delays of the patient. So this some of you must have answered it wrong. So 100% correct answers may not be there in this. Let us now see who has done it right and faster, who are the winners for this. You have next question? Acha, one more. Okay. Overall mortality reduction MI mainly happened because of reperfusion methods. True, false? I'm happy 105 answered and most of them answered it right. But 23 of them still feel it is negative or wrong. Reperfusion is not correct. 23 answered it as a false. Reperfusion they don't believe. Anyway, you might think that thrombolytic therapy reperfusion may not be good. Primary PCI believer, but still that is also reperfusion, either of it. I can think as a false only as that they interpreted that question like that, I think. Otherwise, none of the cardiologists believe that reperfusion is wrong. Next. I think we thank you for the participation. Let us check who is the winners now. Oh, winner is, I think, Number 1 is Dr. Shashank. Can you come up, Shashank? He answered 4 out of 5. That's what I said, you know. One question might be answered wrong, but most of them the time delay I said. That's why, Shashank, can you come and receive the prize? Not here? Oh, come. Ramchandra, please do the honor. Now I think they've listened to it and everybody has answered their names of DOC's dogs coming. The second prize winner is Dr. Vibhuti. What's your full name? Can you tell? Please come. Dr. Vibhuti Pradhan from Orissa. Congratulations. Third prize winner is Satish Kumar. Satish Kumar from Salem. Congratulations. I think, hope you liked some fun and Kahoot gave that, and the idea was to make you participate. We made it a little simpler questions, and afterwards if you find time we'll little more complicated questions and imaging other things if time permits. We'll do it after the tea break. So we request all of you to freshen up and stretch your legs and have tea, coffee break, and reassemble here in 15 minutes after it's now 11 o'clock, 11:15, please come and join back. We'll have interesting structural heart disease talks.
Hello, just two announcements for all. First of all, today also there are 2 CME credit points. So I request everyone to please go outside and have a registration for that. Yesterday 240 doctors have registered. Today only 73 doctors have registered. And other thing is what? All of you have to check out from hotel. So requesting everyone to please check out. So as per the hotel standard time.
Some of the doctors were asking regarding the training, fellowship, further career counselings. We have put a counter there for future job opportunities, career counseling or fellowships. You can write your area of interest, what you're looking at, and your name and contact number in the foundation stall outside. Thank you.
I request Dr. Srinivas to please felicitate Dr. Ramchandra for chairing the session. With shawl, memento and bouquet. Hello. I request all the doctors to please come inside so that we can proceed for next part of this meeting session. So after a coffee break, we are going to go through the structural heart interventions. So we are starting with TAVI case selection, echo CT, when to do and when not to do. After that, TAVI step by step, live in box. And then third session will be of Dr. Rahul. He will talk on Mitra clip case selection and procedural steps discussion. So meanwhile, I also request all the doctors to please, you may have registered for 2 credit points of CMEs. So yesterday there were 2 points and for today there are 2 points. So hope all of you have registered and taken the 2 credit points. And other thing is what, you need to check out from your hotel rooms as per the standard time of hotel. I request backend team to please play our video, that ACVS video. Meanwhile, I request all the doctors to please come on the tables or sit on the chair, and you can have your tea, coffee in your hand, and you can sit onto the chair. Can we have that ACVS video play on the screen? I request all of you to please get settled down so that we can start the session in time. I hope and all of you have checked out from your hotel rooms and you have registered for 2 CME credit points today also. Outside there is a counter, it is placed so that you will get that 2 CME credit points. I think, sir, we can start now. They don't have that video with them. I think they have misplaced it. So we can start from the next part. Still, a few of the doctors are standing outside, so I request all of them to please come in and settle down so that we can start the next session. Yes, sir, over to you.
Yeah, play. Just to make some sound so that people will come in. most of the doctors are in already. We'll start with the lecture. It will be delayed. Thought we'll play that just for some of them we missed yesterday. Can you get this on? Yeah, welcome back for the post-teach session. My colleague Dr. Gokul was supposed to present this tower saver and how the CT helps in decision making, but suddenly became sick, so I had to take that responsibility too. I'll take you through both lectures, then how to select, and then probably step by step of each steps of the TAVI, and keeping the beginners in point of view. And we'll also have a MITRA clip lecture after this by Dr. Rahul. So, what I would basically do is pay our tributes to masters, then how the TAVI evolved briefly and what are the basis data will show, and then how we basically select patients for TAVI, and then which patients should go for TAVI and SAVR. We'll have some discussions, and how the guidelines also evolved. Initially, if I said high risk, now we do it in low risk. It shows a case examples and say what is the future for it. We should all pay tribute to this great man. I think all of you know here. He is Professor Alan Kribia, whom we recently lost. And 15 minutes post TAVI, the patient was awake, and himself said in 2002, I never thought it would have been so dramatic. After that, what is the fate of this procedure? That's what he was thinking. And it went in, and now we are where we are. And lot of credit for our learning should go to this great man, Dr. Shishil Kodali, who is my good friend, and also established a link with facts with Columbia University. I think you know this man, another great man, Martin Billion, whom we started before we joining Apollo decade back. But once we moved to Apollo, everything worked out together, and we started doing more and more towers. We also pay tribute to some of our colleagues in Italy, and then Amsterdam, where we learned some newer techniques. And yesterday I was talking about work-life balance, and that's where if you get a chance, you also try to go around places and enjoy yourself and be happy. That's what we did along with my colleague Dr. Gokul. Then they were so aggressive in Amsterdam, the left main interventions are also being tackled very aggressively. We generally in India had a attitude that left main anyway did surgery, would send both. But both of those, such high-risk procedures, they have been doing it in a 1 hour's time. That's what we got impressed there. This arts clinic in Switzerland, not only beautiful place, I was very impressed because all of them sit together in the evening, both cardiologists and cardiac surgeons, and decide which patients to go for TAVR, which patient to go for TAVR. Really appreciable heart team model to follow. That's why I kept this picture. Then I'm very thankful to our friend Dr. Samir Kapadia, who always helps. And this is a hybrid cath lab model in which they have. This is Professor Reed, through whom we scrubbed for some cases. And this single femoral artery technique, which we recently showed in our recent ACVS meeting, actually what we learned from there. And the Cleveland Clinic, opposite to that, again, Professor Atijani, he worked a lot. He's the one always helpful. How to decrease the pacemaker rates, he did a lot of work on it, and cusp overlap technique, the things we learned there. And we're extremely thankful to all the colleagues across the country, especially my SGPJ alumni who sent patients initially part to gain trouble. Because this side of the country, initially there were some challenges to establish tower therapy a decade back because of some bad experiences. But I'm thankful to all my colleagues, friends who have referred cases, and that's how we could do initially with Sushil Kodali, then we started doing everything. I always, as a career guidance to you, for younger friends, I always tell a point, please keep your hospital's management also happy wherever you're working. It becomes very important to have their support to perform well in career. It is very important for us to think that it's also our job to do something for our institutes too. Many of the doctors have this habit, why should we talk about our organization, things like that. It's not correct approach. If the organization grows, you grow, both of us grow together. I honestly believe it. And this happened very well for us once we moved at Apollo a decade back. And once we did about 40, 50 cases without any complications. And Apollo was happy on one day where we did 5 towers on one day. And that's how they got confidence, and they bought new cath labs. And then probably the hybrid cath lab, senior colleagues, Rath and others also encouraged. And then that's how the structural heart therapy evolved with us. And world over, if you see, many of you might think that why we should learn about it. It's not very true. We have to learn because the number of procedures keep going up. And then probably more and more patients of AS will come, and more percentage of aortic stenosis patients will go for TAVR. In US, it is growing exponentially. See that 75% of aortic stenosis is be treated by TAVR, whereas in India, about 10% of aortic stenosis patients go for TAVR. This is the data for India some time back, but still numbers are further increasing too. Then the TAVI indications, if you see, initially we did only for high-risk surgical patients, but now Partner trial showed that even the younger patients, now the shift is happening, even the younger patients are going for TAVR. But if you see the guidelines, what do they say? So heart team approach, the class 1, no doubt in it, we need to follow. Prohibitively high risk, there's no choice, you have to send for TAVR. And then probably now, we're in a stage where low risk also comes into TAVR. The age cutoff is very important because we have the guidelines to say that valves work well for first 10 years or so. That's why we keep 65 years as a cutoff. We follow generally what is given in ACCHA. European guidelines still say 75. But whoever is less than 65, if you're doing TAVR, you need to have some definite indication whether it should be high risk for surgery or some other problems. Otherwise, we don't generally advise patients of less than 65 for TAVR. That's what the guidelines also share. How these guidelines evolve, if you see, it's very, very important for us to see how Martin Lee has planned the evolution of partner trials and TAVR therapy. In interventional cardiology, the very other few procedures which have improved survival by 3 times. Mind this, standard therapy 11 months, it increased to 30 months. And not only the survival increased by 3 times, the quality of life improves significantly by TAVR. That's the beauty of this procedure. Many of patients who are sick, not able to get up, not able to carry on themselves, go again for voting, go again for jogging. That's how it gives very happiness. Initially, it was started to prevent equivalence to surgery, but it went on to prove superior to surgery. That's how the technology evolved. No one could have predicted so much rapid advances could happen in the evolution of technology. All this happened because of the minimalistic strategy which all of us believed. No general anesthesia, no transesophageal echoes, no ICU stays longer. Many of the patients get discharged the next day. In fact, some of the hospitals are doing same-day discharges. That's how I think the average length of stay is only 1 to 2 days. And surgery, its hours went back significantly because they could never think of discharging the same patient after surgery. How this happened? This happened with a series of trials with partner trial and keeping the patient's interest in the mind with the heart team approach. We come a long way from 6% mortality to single digit and 0.4% mortality for these procedures. It has all happened with a series of partner trials which are planned well. Initially, patients who cannot undergo surgery, later on high risk for surgery, moderate risk for surgery, and finally low risk for surgery. All these were studied very well. The partner one trial, I think many of you, I was initially surprised to know what is the full form of partner. Placement of aortic transcatheter valve. That's what partner trial means. Partner trial 1, when the patient is inoperable anyway, there's no choice, patients do well. Partner 2A, again intermediate risk patients. Partner 2B, sapien valve, the subgroup, all of them came positive. But most important was the low risk group because 80% of the aortic stenosis patients fall into low risk. So our surgeons do a good job again for low risk patients. So we need to have proper equipment, data, to show that we're competing with surgery, we need to perform equally well. That's how the 1,000 patients in each of these groups were followed up meticulously for a year, then 3 years, then 5 years. Then what it showed, death, stroke, and rehospitalization, that's the endpoints. The surgery is 15.1%. Interventional cardiologists, we are wanting at least TAVR to reach to that expectation. But what it did do, it performed much, much better. 8.5%, half of the surgical group what it had. So that's how it has not only proved itself non-inferior, but it proved superior to surgery significantly. What happened to strokes? Again, strokes were significantly less with TAVR. Death, disabling strokes when combined together, again significantly less with TAVR. If you see any primary subgroup endpoints, any age group, whether male or female, high risk or low risk, any ejection fraction, any functional class, all of them had significantly better performance with TAVR. And some of the complications are being seen as secondary endpoints. Obviously, I would say they come positive with TAVR. Length of stay, atrial fibrillation, bleeding, all that would be less with TAVR too. So obviously, many of them proved positive compared to others. And the only problem where we had performed badly is the vascular complications and the pacemaker implantation rates. So that's how I think a partner, initially surgeon said 1 year data is too short, then we extended it to 5-year data, still it is maintained. Aortic valve areas, many people thought it will degenerate, but valve areas are maintaining. Regurgitations were initially a challenge, but with better paravalvular cuffs available for these valves, regurgitations are also decreased. So that's how with the 5-year data, both of them performing equally. If we now see in 2026, surgery is better in very few things. Most of the times, see that so many advantages of TAVR. Mortality less, strokes less, hospitalizations less, kidney injuries less, quality of life is better. If somebody asks which one you think is better, you don't need great pains to prefer TAVR. So, but sometimes you have concomitant other valve disease too, or left main coronary artery disease too. That subgroups were also analyzed, and the TAVR did better even that concomitant disease patients too. So how this is happening? Because the valve, Edwards cell balloon expandable valve, is like a stent. Take it there, implant it. It just behaves like a surgical bioprosthesis. What surgeon is cutting and putting, we are doing percutaneously. That's how I think it proved itself. Then Evolute, a Medtronic company, was also working on the other front with Evolute low risk trial that also proved itself and came with a very positive trial results. And so much positive that the valve areas, the clinical implications were very better, and the hemodynamics were much better compared to SAVR valves. This came as a further surprise. The surgeons were not able to take it because this has a self-expanding supraannular valve. The valve areas were better, gradients were much less. So that's how I think Evolute also tested the long term, and it gets proven positive, both the hemodynamic size and valve area wise. People said it is a trial and directed by companies. Then independently UK TAVR registry was done, again showed that it is non-inferior to surgery. See, this low risk TAVR journeys and the same day discharges and clinical outcomes significantly improved now. Then people argued out saying we need to have independent of any studies together, whether it is a one company valve or other company valve, it doesn't matter, you have to prove yourself. That's why dedicated trial was planned in Germany. It is not sponsored by any company. It is just comparison of real world strategies. Some of the patients go for balloon expandable, some go for self-expanding, some for surgery. So that is all valves together, 60% of those Edwards and 40% were self-expanding, and no company sponsorship. Here also, TAVI performed better. Actually, the problems were half the surgery. Again, it came out very positive, and compared to death from any cause, non-fatal strokes, and then any other trials, safety-wise, also the TAVR performed better. Then we should appreciate our company, Indian company Merrill, MyValve. They did a landmark trial analysis, again comparison of SAVR with the other valves with Merrill valve. Then it showed that that also works well. Notion tool trial, again a long-term comparison, showed that again the TAVR was working well. This is registry performed by Yale University, again independent analysis, where they followed up, clubbed up all the data of long-term because they wanted to see long-term follow-up, and then statistical analysis. I won't go into details, but it's total of 8 trials, low risk versus 4 of low risk, 4 of higher risk were analyzed. What it showed, all-cause mortality again favored TAVR. Then both in high risk and low risk groups. Strokes again favored TAVR, both in high risk and low risk. So disabling death and strokes again favored TAVR, both in high risk and low risk. All the secondary endpoints came significantly positive with TAVR. So independent registries also showed the same. We had a partner trial, Evolute trial, then dedicated trial, which is not by any company. Now registries also showed that everything comes positively in favor of TAVR because it is true. So that's how they concluded, showing that the shorter hospital stay and better outcomes, and it's proven beyond doubt. That's how it, now they keep it in the clinical context. Now even the surgical mortality is accepted surgical mortality, I'm saying, is around 2.5%, but we have 0.4% in TAVR. That's important. Some people argue out regarding the timing of LV dysfunction patients. For the sake of time, I couldn't go into details, but basically the earlier you do in patients of LV dysfunction, the better it is. Sometimes the undergoing coronary artery disease, if if a patient has CAD, then there's a controversy saying whether to do CABG or doing PCI plus TAVR. Again, many of the times it came out that coronary artery disease doesn't really matter unless it is proximal left main or LAD, and that's how we can do TAVRs in presence of CAD too. So that's how the SAVR versus TAVR. Now the argument is, now in PCI's left mains, we don't discuss whether it's CABG or surgery. The same thing, I think now TAVR, we are changing. Transcatheter valve technology is a game changer. That's what Michael Mack, surgeon, said. The heart team factor is important, and if suppose young patient wants surgery, I think you should counsel them, tell them it's not appropriate to go for surgery, and then counsel them and allow patients not to make stupid choices. That's how we need to express our good officers and influence on patients. Indications, not only high risk, low risk, surgically unfit, but even low risk patients, expanded indications, now we go for TAVR. Now, the timing of the journey of planning tissue of these patients becomes important, because low risk patient is totally low risk, doesn't want any complications. That's how the low risk is. So, if a patient is younger, generally goes for surgery. Patient is older, more than 65, goes for TAVR. In between, we have a shared decision making process, and that's how we decide. So, in young patients, low risk, we need not have any of these problems because we want the perfect results. So that's how I think we are evolving further. Only thing which is bothering us now is the long-term results of these patients, how the valve behaves in the long-term, durability issues. And then one little problems happening occasionally with the vascular complications, which we are not totally there, like surgeons, and conduction tissue abnormalities. To decrease these vascular complications and increase the longevity, research is going on. The Seagull is a new valve, revolutionary system, which is a 9 French system. The tissues by which it is made and the metal is totally different, where it's supposed to last longer. So we want to increase this 9-year persistence rates to further. If a patient, if an implant can live for 15 years, then that will be good. So as of now, we plan a lifetime implantations, keeping that valves last for 9 years. That's how we plan. TAVR first or TAVR, depending upon type of patient presentations. Notion valve, surgeons also criticized, but in their surgical trial also, our valves did better. The research is going on in surgical front too. It's also good for us, healthy competition. Resilia tissue valve, which is made for surgeons too, is working longer, they say. So, but we also incorporated that. Edwards did that for our Edwards Sapien valve too through Resilia. With each passing year, unknowns becomes known, and the future of TAVI appears to be more and more bright. Whatever trial you do, whatever challenges you do, it comes out as a winner. So that's how it is. The Foldax is a live polymer which are working on, as I said, duration of the valve leaflets. If this is supposed to last longer for lifetime. So if that happens, then they are coming up with a valve also, then lasting of valves after more longer for 15-20 years could happen. So in today's era, you have to do which is favors SAVR, which favors TAVR, basically younger age group, and anatomy wise what is important, where the patient has very high risk anatomy for TAVR, that's what we need to see. We are not bothered whether the patient is high risk, low risk, but if any particular indication like iotopathy or multivessel disease, patient has concomitant valvulopathy or younger age group, they tend to go for surgery. And any contraindications for TAVR like low coronary ostia, things like that also sometimes would go for TAVR. Then the elderly patients, high risk patients, obviously they will go for TAVR. The 5 golden rules for TAVR, again should be TAVR should be agnostic for TAVR. Elderly comorbidity patients favor TAVR. Transfemoral axis is again is compared, please. Don't go for crazy stuff like transcarotid, IVC punctures, things like that. And age is important. Anybody who's less than 65, if you're doing TAVR, you need to have some good reason for it. Any unfavorable anatomy, even if it is a little higher age group, like chunks of calcium, low coronary height, where you can't deliver TAVR properly, still could be surgeons who will do a good job in that. Patient preferences matter, and shared decision making, keeping patients' interest in you, should be taken as top priority for us to decide about it. Eugene Braunwald, we all recollect this great man whom we recently lost. He said in the low risk TAVR, this historic movement, and all of us here should remember it as such. And whereas TAVR's paradigm shift has happened in this treatment of these patients. So in this era today, we are not bothered who does poorly with surgery. We now discussed who is there any contraindications for TAVR. We did procedures in not only high-risk patients, in all these subsets. For the sake of time, we couldn't show case examples. But final thoughts are basically TAVR works and patients and the doctors want a less invasive therapy, and then probably in the future we are able to tackle all further diseases even in moderate AS, and AR also we started doing it. The upstream therapy with without waiting till the patients go into severe AS with these novel technologies like this also are being planned for these aortic stenosis patients. Why we struggle and do all this is we want our patients to do happy. This patient immediately got up the next day. This patient went to vote, referred from Nagpur, went to vote later. Such a patient with an IV infusions before TAV. So that's how I think the procedure has established itself. I'm finished my 15 minutes time for this, and we go on to the next talk of step-by-step analysis of, I'll show you how the CTs are helpful to interpret. After the data analysis, then I will show you steps of tower also in that. Can you get this there? Yeah. Okay. I think we'll have discussion after the end of both talks because both are depending upon TAVI. So what I like to show in this previously data and how the tower established itself compared to surgery I showed. Now I'll take you through this case selection and how the procedure is done with examples of both balloon expandable and self-expanding valves. It's very important for heart team to really function as heart team. That's where I think even good corporate type of hospitals or hospitals with good setups where you have all the facilities available with everybody together has got into practice again. Now the PCIs have established and single-centered centers have established about now structural heart therapy is one where you need real good teamwork where cardiologists, surgeons and other colleagues like critical care specialists, ICU care and everything comes in play, including radiology colleagues. You need to be right to have good relations with the radiology friends so as to interpret the CTs properly. So what I would like to is to basically tell you the steps of TAVR, and patient evaluation becomes very important clinically to assess patient. It's also important for us to see how the symptomatic correlation to this aortic stenosis is happening. Many of the times patients are being treated in asthma, COPD, many of the times we see patients coming to neurologists, various presentations I've seen. Patients are being treated as syncopes or seizures with aortic stenosis. Patients are being under pulmonology follow-ups. Recently, doctor's mother was getting regular treatment with the pulmonology colleague, and then somebody had a seizure. So why I'm telling all this is presentations could vary because the elderly patients, they may not have a classical triad as described, but many of the times could be there. But in spite of all that high index of suspicion, if you put stethoscope, auscultation becoming out of vogue, again here it plays important role. If you auscultate the patient, significant murmurs and then radiation carotids happen, but sometimes it could be masked because of patient's chest deformities and things like that too. So later on echo helps us to assess the symptoms, and nowadays you have to assess the echo stenosis correctly. Continuity equation is being followed left and right with various patterns, but I request to always correlate of the symptoms and see the anatomy of the valve. Now we are in the stage where to select the TAVR patients correctly and then see the echo parameters, how it is doing, and then also assess for the other valve involvement, also assess for the coronary artery disease and the peripheries too. All this happens not only on echo but on cardiac CT. Cardiac CT tells us everything. It tells us about the valve anatomy, dimensions, deployment angles, and then probably estimate the risk of pacemakers, LVOT obstruction, things like that. Nowadays we have three-dimensional reconstructions happening. We can rotate and see carefully, and then that's how we can make out aortic calcifications, where the valve needs to sit and all that very clearly. Three-men-show software is a friend for us. Don't get away from it. If you do not have three-men-show software, there's free softwares available on the internet too, where you can practice. In a lot of hospitals have EchoPack systems and AngioPack systems where the measurements are still possible. or we should become comfortable, don't go only by the company reports, and the calculations of annulus becomes important because obviously size is dependent on it. So valve sizing, how we are doing, we see analysis of CT and then see this, the symmetry, the oval nature. Sometimes I will take you to some examples where the calcium chunks, all that can be clearly seen. Other things which have to be seen apart from the size is the distance of coronaries from this valve plane and the peripheries, peripheral vessels, how which is are there, because it's important to do avoid the local complications too. The valve sizing, the finally depending upon the annulus diameter and the perimeter, we decide upon the what type of valve we use, and that's the most important to avoid parallel leaks and also prevent complications like aortic ruptures. This is some of you are not exposed to this is the cath lab setups. What is done? We in the coronaries we used to have only this. Here our therapy specialists also come into picture. The company people also come into picture, prepare the valve, because as of now it was not a dry tissue, though one of the latest valves is launched, we can directly take it and deploy it in the patient, but as of now they need preparation. That's how this extra table you are seeing it here. Then the echo machine can be here, and anesthesia colleagues inside staying in the lab also becomes very important, because a great help during the procedure. If there is hypotension, something is happening, we ask other friends to give little anesthesia drugs more to increase the pressures. That sort of support is very important. What is exactly done in a CT OT theater, we are trying to replicate in our cath lab. So that's important to know the setups. So vascular access again becomes very important. Guide wire management, some of the steps I will take you through. Vascular access, wherever there is access, we are trying to do it. The standard femoral access, what we thought during our student days is very important. Just prick on the main femoral artery, and how to do it, I will take you through steps if available. These are the various hardwares, you should keep it on shelf. Various wires which are required. For sake of time, you can take pictures or we'll have the slides circulated to you, all to be kept available in the lab. See such tortuous anatomies, but 3D reconstruction shows everything so easily, and that's the importance of analysis of CTs. And then you can get a longitudinal reconstructions of everything. You can, after you decide now which side you go, this doing a puncture becomes very important. Even today, even the best of the sites, the maximum time is taken to get vascular access. Once it is done correctly, the rest of the procedure happens in less than half an hour's time. So you go from the other end, put a catheter there and see, this is the point where we want to do exactly on the femoral head. Sometimes such tortuosities, it could be difficult for us to you to assess. Then exactly that is the point you decide. You can't go below, there is a bifurcation. Above it goes to more of a problems of retroperitoneal hematoma. So we aim there and try to do puncture. The micro puncture technique, if you have it, it is very easy to do it. It avoids complications. We recommend you to do it. Once you do that, then you check it, whether done it a correct puncture. That is done, then you also get access to temporary pacemaker, especially balloon expandable valve, very important to have it. One person should be exclusively controlling temporary pacing for that. Then aortic valve crossing, we use a AL1 catheter and use cross with a thermo wire or a extra stiff wire depending upon your comfort. Once it is crossed, then you take the catheter inside, exchange it with the pigtail, and probably take a LV pigtail trace like that. Then exchange, once the pigtail is done, you put a stiffer wire inside because the valve goes on the stiff wire. And once that is done, valve check has to be done whether valve is deployed right or not, because the cuff is here, it has to be distally located. If it is reversed, then valve won't open. The patient will have trouble on table. So you're taking the valve, taking it, and any point of resistance, again I keep telling, cath lab is not a place to show your power. Any point of resistance, please analyze what is the cause of resistance, reorient the wire and see and try to pass it smoothly. Then that's how native valve crossing. Sometimes we need to take the help of peridilatation, sometimes it may not be required. Then hemodynamic monitoring, anticoagulation monitoring, very, very important by our anesthesia colleagues which are there side by, and again keep a CPB machine and standby ECMO machines if possible. Again, this coplanar angles, I can't go into each details for sake of time, but it's important for us to follow some principles of positioning the valve correctly and check the valve. Take the contrast injections and see aortic root checking and gradually deploy the valve. The advantage of self-expanding valve is till the 2/3 of valve is released, 75% still it is under control. And if you're totally happy with the way the valve is released, taking the picture, then only we can have the final release. You come releasing it further. Then once the valve release you are happy, then it is released totally. You can check by echo. Interventional echo is also coming up in a big way. Some of the friends who are interested for echo is a real good opportunity because not many people are comfortable, especially my next talk coming, Rahul Chaudhary. It's all dependent on echo. So mitrectomy procedure. Though it is also important here, but less dependent, I would say. But you can check on the echo too. The paravalvular leaks, the 3D echoes, all that help for us to do a good job. Once everything is comfortable, you do the final release. Once you do this, then it is reversible. Removal of delivery sheath has to be done very carefully. Then you take a femoral shoot, again angio for AR, and then you also check the femorals. I'll show you some case example of 81-year-old doctor who was referred post CABG, again has multiple issues of age-related dementia, not suitable for surgery, and then that sort of calcific aortic stenosis, thought to be unfit for surgery. Pre-procedure echoes were done, and then gradients were calculated. Then also see that this is the CTs again which are analyzed. This is important. I want to show this CT. If your guide settings of a CT are not good, you feel everything is calcific. When you analyze it well, then probably you feel now you can confidently do TAV. It's important. That's how to learn the settings of radiology along with colleagues too, and then decide on the axis to it. Then report analysis, calculation regarding other things become important. And the coronary angle heights, deployment angles, all that is decided, pre-decided before the patient is taken onto table. See this is what I mentioned. Lot of calcium here, which could have gone undetected if the analysis was not done properly with proper adjustments. Then we had to do dilatations, and then probably finally we could take gain settings adjustments, and finally we could take the valve too, and we did the procedure successfully. These are key steps. Each of it again I'll go through the pictures. This is again the analysis of the puncture site. If you have a Doppler ultrasound bedside, it is always better to follow it because it helps you to puncture exactly in the anterior portion, not on the sides. That's the advantage if you do with the Doppler guidance too. The bedside ones are also available now. So after you do that, then you pass the wire. That's what I said. Again checking the other side. These are steps again to show someone balloon expandable valve. Now you see it is punctured well. Then initially take the dilators. The same steps again being repeated for the sake of time and going fast. Then you see where are you positioning the valve, crossing the aortic annulus, aortic valve, placing the stiffer wire, checking the gradients, then positioning the valve now. It's always better to keep a pigtail in the sinus so as to, it works as a landmark for aortic valve for us. And then you take the valve inside now. Sometimes you predilate if there is too much of calcium, very critical aortic stenosis. Predilatation, we generally do it with a little smaller sized valve because if you take too big aggressive dilatation, you could produce more severe AR, patient could land in trouble. So minimal annulus, what is it you take and accordingly predilate once. Then once the predilatation is done, you are taking the valve now. Then at the crossing of the aortic arch, you need to be a little careful, again not to get into too much of resistance onto the arch. And place the valve there correctly. And then there are markers now in different companies have different markers, and you analyze and keep it correctly so that it becomes easy for us to deploy the valve. You always can control during deployment also. Once you see that, once the valve is positioned correctly, then you pace it rapidly and then you deploy the valve. See that valve is expanding, 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 and then finally it stays. And you also do sometimes called second dilatation to keep the paravalvular leaks and other things less. You check on the aortic angio again, take a picture, and you also check on the echo to see how the valve is seating, and then remove everything later. And previously patients have no ASAR and no gradients. That's how the successful procedure is done. Sheath removal again becomes important, and finally the percutaneous closure with closure devices is important. This is final check. It's also important to do it right. Until this last moment, vascular closure checking is done. It is not yet done totally because many of the times you could have vascular access problems too. Always be careful to do that. So pre and post procedural echoes are important, and the follow up again you will do it on echo. So what gradients were left out immediately are important. somebody wanted to see Sentinel device protection, if it is actually not available now, I'll just show you how it is taken. The Sentinel devices are put in both carotids. So that left one goes first, then both are filters are placed there. Rest of the steps are same like in the previous case, crossing, dilatation. This is with a Edwards valve, I think. Then placement, expansion. Once the valve is deployed, then sentinel filters are removed, and that's how the patients do well. But now the trial data showed that didn't matter much. That's how the valve company has removed it, and it's no more available in our country. Protection devices. That now that this device is being released out, again the final check of the femoral vein artery. So that's how I think we are able to do these procedures successfully. Now, friends, now today I think in 2026, heart team approach is the key, and we need to have a clinical, echo, CT evaluations and look for any high risk features for TAVR. We're not bothered whether patient is high risk, low risk or moderate risk, but patient is whether fit, whether they can deliver good result for TAVR or not, what we need to see. And whatever you are comfortable with, balloon expandable or self-expandable, become comfortable with one of it, but ideally you should have one of each, because some patients who have small annulus, patients which are more suitable for self-expanding valve, or some of them where patients are sick, where rapid deployment is to be done, balloon expandable could be preferred. So in the keep patients' interest in top, and God will cooperate for us, and we'll achieve optimal outcomes if we do procedures with good intention to these patients. With this I stop, and I'll be happy to take any questions. Thank you. How many of you sitting here are already exposed to structural heart and TAVR interventions? Can you raise your hands? About 30% of you are exposed. That's a good thing. I think it's gradually picking up in many other more centers. It is coming up. Previously, it used to be thought that why we should learn about it and all that. But now, because the procedure has established itself, and now sometimes I am happy to say that our TAVR times are less than a complex, not a simple PCI, but less than a complex PCI time. We finish in less than hours duration most of the times, unless there's a problem. Actually, the less time taken, the patients have better outcomes. That's what we have noticed. But somewhere you are stuck means will be a problem. The problem with TAVR procedure is, it is not excusing if you do something wrong. Immediately patient succumbs on table. If you put a bigger size valve, or the valve is not seating well, or coronaries get obstructed, or some tamponade happens, immediately patients succumb. That's the only thing. That's why we need to be careful and have a surgical backup available too, in case if to be used. We just keep them happy in console rooms with coffees. Luckily, we need did not have the opportunity to use them on tables. Very rarely some vascular complications I might have repaired one or two, but for that I don't remember patients directly going from TAVR to surgery. That's the state where we are, and I think more work needs to be done in the times of newer valves coming up, where the longevity, we are looking now towards valves which can work for 15 years, 20 years to these patients, so that even younger patients could be offered this therapy. Thank you again. Questions? There are no questions, then we'll go to the next talk of mitra clip. And basically, Rahul, I try to keep it a little more basic side because of younger doctors here, and then we'll take questions later. Okay? Thank you again. Deepak, you introduce? Okay.
Thank you very much, sir, for this wonderful session. So, do we have introduction slides ready? Please let me know if it is ready. No? Okay, so If it is taking time, then we can move forward then. Okay, anyways, let's move to the next part. So today next part is that Mitra clip case selection and procedural steps. For this we are having Dr. Rahul Chaudhary. I request to play the introduction slide of for Dr. Rahul. I request Dr. Rahul to please come up the stage and please deliver your talk. Hello. Dr. Rahul Chaudhary, he is a consultant interventional cardiologist. Expertise in complex coronary intervention, transcatheter aortic valve implantation, TAVI, mitral tricuspid, structural heart interventions, and cardiac pacing therapies. Completed fellowship in adult structural heart interventions at the University of Heart Center, Medical University of Grays, Australia. Experienced in TAVI, mitral and tricuspid TEER, left atrial appendages, the closure, pacemaker implantation, IABP insertion, and impella management. Doctor has secured All India rank 13 in FNB Interventional Cardiology 2021 and All India rank of 300 in NEET Super Specialty Cardiology 2018. He is recipient of Dr. Vijay Vishwanathan Gold Medal for Best Paper Presentation at Tapicon 2017. He is an active researcher with publications in interventional cardiology and participation as principal investigator and co-investigator in international clinical trials since 2019. He is a regular presenter at leading international cardiology conferences including EuroPCR, ESC, Asia, London Valves, and TCT. Welcome, sir. Over to you.
Good morning, everyone. Thank you, Srinivas sir, for giving me this opportunity to do this presentation in front of all the budding cardiologists. So the topic for today's afternoon that I'll be talking is mitral edge-to-edge repair, case selection, and procedural steps. I will try to keep it as simple as possible, and let's start with basics. So many times when we do echo, we just say there is MR, but most of the times we forget to classify it. And it's very important that all of you should know about the famous Carpentier classification, like the type 1, where you have normal leaflet motion and position, type 2, where the leaflet motion is excessive, and type 3A, where the leaflet motion is restricted in both systole and diastole, and type 3B, restricted motion only in systole. So when you see primary MR, essentially type 1, type 2, and type 3A are included. And in secondary MR, in atrial secondary MR, usually it is type 1, and in ventricular or ischemic MR, it is type 3B. On the other side of the slide, you can see various types of MR and how the leaflet behaves, and you can see the jet direction as well. So before going forward, what do the guidelines say? We have guidelines from Americans from 2020 and Europeans from 2025. So the 2020 ACC guidelines for primary MR give a class 2A indication for high surgical risk patients who are symptomatic with expected life expectancy more than 1 year. Similarly, European guidelines give tier for primary MR a class 2A for those patients who are symptomatic and are deemed high risk according to the heart team. And there should be anatomical feasibility as well. So what are the landmark trials for primary MR? If you go for landmark trials for primary MR for MitraClip, it is the Everest 2 trial, where 73% of the enrolled patients have a degenerative MR, and there is a significant reduction in mitral regurgitation, but little less than surgery, but it's a positive trial. And for Pascal device, you have the CLASP 2D trial. We have other registry data like the expand and expand G4 and clasp it 2D, where the results are quite encouraging with regards to the mitral edge-to-edge repair for primary MR. So where do we stand with guidelines for secondary MR? Like the American guidelines, you can see those patients with severe MR who are symptomatic and LV ejection fraction less than 50, who are symptomatic despite guideline directed management, with a favorable anatomy where the LV ejection fraction should be more than 20% and the LV end systolic dimension should be less than 70 mm and the pulmonary artery systolic pressure should be less than 70 millimeters of mercury. They receive class 2A indication for transcatheter edge-to-edge repair. The latest European guidelines, you can see for secondary MR, MTIR has been given class 2B, class 1 indication for patients who are symptomatic on guideline directed management. And interestingly, for patients planned for LVAD and heart transplant, if there are contraindications for immediate heart transplant or LVADs, or if the waiting periods are longer, it has been given class 2B indication. So this is a very interesting slide where various morphologies of secondary MR has been described. You have various morphologies like proportionate MR, disproportionate ventricular MR, mixed atrial and ventricular MR, and atrial secondary MR. So what is essentially a proportionate MR and a disproportionate MR? So a proportionate MR essentially means that the ventricle is good and the effective orifice area is large. So it means that the pumping function is not that bad, but still the MR is very high. What is a disproportionate, what is a proportionate MR? Where the pumping function is low and the MR is equally proportionate to the LV function. So what matters is the ventricle that you are clipping is what matters the more. So always a ventricle with relatively good LV function with severe MR fares better than a poorly functioning ventricle with MR. So these are the trials and registry data which support mitral edge-to-edge repair in secondary MR. You have the MITRA FR, which is a negative trial, and a COAPT, which is a positive trial. So the lesson learned from both the trials are, you should know when not to clip in all those patients who come under the MITRA FR category, and those patients who come under the COAPT category, they are good candidates for clipping in secondary MR. And you also have encouraging data from Reshape, where even patients with effective orifice area less than 0.5 are still worth acting. If you also see the registry data from the expanded 2025 and STS and TVT registry, even those patients who don't fall under the COAPT criteria, they are having reductions in heart failure hospitalizations when undergoing this mitral edge-to-edge repair. So how do we work up a patient who comes to us with MR? This is the initial imaging workup pathway. The first thing is the transthoracic echo, where you do a transthoracic echo, you identify the severity, you identify the etiology, you see the LV ejection fraction, you see the LV end systolic dimensions, PA pressures, and then you do a TE to confirm the mechanism, identify the effective regurgitant orifice area, the leaflet and annular anatomy, and then you have a heart team discussion to review the risk, anatomy, and whether the guideline directed medical treatment is going on, and then you plan the procedure, where you take the device size and you also discuss on the transseptal height and the clip strategy. So what is the role of interventionist? We have to correlate the fluoroscopic findings and the intraprocedural TE findings in real time. So it is very important that we know the anatomy that we are dealing with, and we understand it well so that the outcomes of the procedure will be good. So when you do echocardiographic screening for a patient who is supposed to undergo a clip, so the things that you should look for in the echo are, one, the coaptation depth. So this coaptation depth is very important for grasping. Next, flail width and flail gap. So the flail width and flail gap essentially guide the number of clips needed. And the mitral valve area is also very important because it is very essential to calculate the residual mitral stenosis after the clip. And the leaflet lengths are also very important. You should also be cautious about the extent of calcification, because there should not be calcifications at the site of grasping. And also be aware of any clefts, perforations. So annular dimensions are again important because if the annulus is very much dilated, the clipping cannot be optimal and we'll end up in complications. So subvalvular anatomy is also again important to identify any calcifications, and there could be possible interaction between the clip and the subvalvular apparatus. So if you see TE, essentially in plaques view, you can see the pathology. In parasternal short axis, you see the planimetry. In 4-chamber, you assess the LA, LV, and MR quantification and other semi-quantitative things. And in 2 chambers view, you can identify from which commissures the jets are coming, and you can identify the MR width. So what should we know from the transthoracic or transesophageal echo? Basically, we should understand where and why does the coaptation fail, and how whatever interventions we do will alter this presentation. So what extra information transesophageal echo gives is, can it be fixed? If it is fixed, how can we fix it? Like the number of clips, the location of the clips, the location of the jets, all this extra information is given to us by the transesophageal echo. So when you screen a patient for mitral regurgitation using a transesophageal echo, so the questions that you ask are what in the mitral valve apparatus is causing the valve to leak? Like what is the etiology, whether it is a primary etiology, if it's a primary etiology, whether it is a prolapse, whether it is a flail leaflet, whether there is any other pathology causing the valve to leak. So if the leak is there, how severe is the leak? So if at all we are planning a transcatheter procedure, is it safe to do a procedure? So all this information is essentially obtained from transesophageal echo. So once we identify severity of MR and the pathology of MR from transthoracic echo, then we move to the transesophageal echo. When we do a transesophageal echo, there are some standard views which help us in identifying the pathology as well as identifying the leaflet and also leaflet lens, etc., and also help us in planning the procedure. The essential views are bicaval view, short axis at base, or bicom view, and 4-chamber and 5-chamber view, and 3D on-force views. So let us see some of the So you start with long axis 4-chamber view, where you go from the upper esophagus to lower esophagus, and essentially in this view, the information that you get is, as you go from high in the esophagus to lower in the esophagus, you image the valve from lateral side to medial side. And when we come to the intercommissural view, that's also the bicom view. You rotate the probe from clockwise to counterclockwise to sweep the leaflet from anterior to posterior side, where you can understand the pathology or the anatomy of the leaflets. So essentially in this intercommissural view, we can identify the segment which is prolapsing. If there is a prolapse segment, you can also identify the width of the jet. And in this intercommissural view, you can sweep from lateral to medial using explain in your echo. So precisely you can identify the origin of the jet and the direction of the jet. So here in this slide, you can see how in this intercommissural view, we are able to identify the width of the jet. So then after assessing in the bicom view, then you can always go to LVOT view, or in the same existing bicom view, if you put a explain, you'll get this LVOT view. Essentially, this is the view where we grasp the leaflets. So it tells us various information like the length of the leaflet, the direction of the jet, and also it is the view where we go and grasp the leaflets when we are clipping. So here you can see this is the view to grasp the leaflets, and in this view we can also identify the length of the leaflet as well as the location of the calcification, or if there is any calcium that is present on the grasping segment. So finally, whatever information we get from a 4-chamber view, a bicommissural view, or a long axis view, we put everything together and then we obtain the 3D on-force view. So 3D on-force view basically gives us a global view of mitral valve leaflet anatomy. So we can identify where there is a prolapse segment, the direction of the jet, all these kind of information we can essentially get from the 3D on first view. And when we are positioning the device also, it helps us to identify our orientation of the device with relation to the leaflet. So this pre-procedural transesophageal echo can help us to devise a strategy of understanding where to clip, how many clips we would probably need. So once you put a first clip, if there is a significant reduction in MR, you need not go to a second clip. So as the reduction in MR is, as the MR reduction that is optimally expected is 1+, you also take the clips according to the procedural outcomes. So this is a very famous slide, which essentially mentions about the complexity of the anatomy, basing on which you can select the candidacy for the mitral edge-to-edge repair. So if you see a non-complex procedure is essentially when the pathology is central, there is no calcification, and the mitral valve area is 4 centimeters square. And when you have a posterior leaflet length of 10, and tenting height is less than 10, and flail gap of less than 10. So as the center's experience and the operator's experience increases, you can also opt and go for more complex anatomies. So complex anatomies can be those jets originating from the medial commissures like the A3, P3 segment, or the lateral commissures like A1, P1, when there is an annular calcification, when the mitral valve area is around 3.5 to 4, when the posterior leaflet lengths are less. So these are some of the complex anatomies which the operator should be watchful when he is about to perform a mitral edge-to-edge repair. And when you are starting your first case or initial cases, it is always essential that you choose non-complex anatomies to begin with. And as your understanding of the device increases, as your understanding of the procedure increases, you can gradually go for more and more complex anatomies. So what are those anatomies where strict replacement should be considered? So when there is concentric mitral annular calcium with stenosis, and the mitral valve area is less than 3, and the mean gradients are more than 5, and posterior leaflet length is less than 5. These are some of the important anatomical considerations which should alert an operator not to consider mitral edge-to-edge repair. And mitral edge-to-edge repair has not been, is not recommended in mitral stenosis, it is not recommended in leaflet perforations, and when there are multiple jets and very wide jets, then also doing mitral edge-to-edge repair is little risky. So once you screen a patient for MR and you do a transthoracic and later transesophageal, so essentially what these are the criteria which you should see, that the valve area should be more than 5 and the posterior leaflet should be more than 6. This is almost a continuation of the previous slide, so I'm not going into details. So what is the advantage of doing this procedure? So basically, this procedure is essentially offered to those patients who are considered high risk for surgery. So it's a minimally invasive beating heart procedure. There is no cardiopulmonary bypass. And it also allows us for a real-time MR assessment, and we can also reposition the clip always, and it's a very controlled procedure. And the patients are out of hospital within 2 to 3 days. So again, another important step in mitral edge-to-edge repair is the selection of the transeptal puncture. So the transeptal puncture height is again very important. So when you are doing a transeptal puncture, these are the standard views that you use. One is the modified 4-chamber, where you can see the length of the you can see the location of the transeptal puncture from the mitral annulus, and the short axis at base, which tells you whether you are anterior, posterior, bicaval view, which tells you whether you are superior or inferior. So these are the optimal locations for punctures. So if you see for PFO closes, generally it is superior anterior. If you are doing some paravalvular leaks, probably anterior and mid. For MitraClip, TMVR, PVLs and all, it is posterior, mid, or you can always go posterior inferior. When you are choosing for a LVAD and septostomy, it is usually a central procedure, and left atrial appendage, you can see it's a posterior inferior. So when you are seeing a patient with a non-central MR, for medial jets, higher initial transeptal height is needed. For lateral jets, lower initial transeptal height is needed. So this is a slide which essentially summarizes the entire procedure. First you do a transeptal puncture, you cross the intraatrial septum, then you put the steerable guide catheter and the delivery system. Then after inserting the delivery system, you steer the delivery system by advancing the clip from the left atrium into the line of coaptation. So once you advance, then you grasp the leaflets, you assess the hemodynamics. If you are satisfied with the hemodynamics, then you deploy the clip and come. So the current available MT devices in India, as you see on the screen, are Abbott MitraClip G4. So there are 4 types of clips. One is G4NT and NTW, G4XT and XTW. So NT and XT basically they differ in the lengths, and W means wide. Next slide shows you a detailed description. As you can see, the width of the NT device is 4 and the width of NTW is 6. Likewise, the grasping area of W, the wider jets, is more than 50% of the narrower jets. So the other device that is currently available is the one from Merrill, MyClip. Essentially, the dimensions are same, but they are named differently. So how do you choose a device, whether a longer wider or a shorter wider? So basically, if you have a narrower jet and a shorter leaflet length, you go for an NT. If you have a narrower jet and a longer leaflet, you will go for an XT. If you have both longer leaflet and a wider jet, then go for XTW. If you have a shorter leaflet length and a wider jet, then go for NTW. So these are some of the few cases which we did using MT device. First case is a 72-year-old male who is a diabetic CKD, COPD. He had PCI with RCA with 3 drug-eluting stents due to posterior wall MI long back, and he stopped taking antiplatelets. He came to emergency with chest pain and shortness of breath. We diagnosed him as NSTEMI, and you can see the echo which is being played, which showed dilated LV with severe LV systolic function and severe eccentric MR. So the baseline coronary angiogram, you can see a distal left main probably looks like a trifurcation disease, and the RCA angiogram which was done long back showing complete occlusion. So how did we approach? First, according to the clinical picture, whether we should do a CABG with mitral valve repair or replacement, or any other solution that we can offer. But since as the patient is decompensating and requiring higher cortical amines, we needed to do something that is urgent. Then we thought, is surgery the only way forward, or is there any other way to bail out? So considering the high mortality of the patient with regards to CABG and the leakage of the valve, we explained the patient's the condition, and we took him up for a chip PCI using mechanical circulatory support and mitral edge-to-edge repair. So we inserted an impella and prepared the lesions with various balloons and calcium modification, and we did a decent job with PCI. I'll show you the final result. So you can see the coronaries have been sorted. Patient remained stable during the procedure. Then after stabilizing him for 1 or 2 days, but the leak didn't come down, then we took him up for mitral edge-to-edge repair. You can see the echo being played. In the second video, you can see there is still severe MR, and in the third 3D view, you can see a posterior directed jet. So then we started proceeding for the procedure. So first we did a transeptal puncture. Then we advanced the device, and we identified the jet origin. We tried to position the device across the leak. Once we identified appropriate position, then we started opening the clip arms, grasped the clip arms, and post-clip you can see the reduction in MR. So the entire procedure was done under general anesthesia with the transesophageal echo guidance. So this is another case who is a post-CABG case, diabetic, same multiple comorbidities. He is having multiple hospitalizations due to heart failure. We are not able to titrate his medications due to underlying CKD and blood pressure. So we did a coronary evaluation, all the grafts were patent. So patient looked very frail. So considering his general condition, we thought surgery will be high risk. So what did we do next? We used Merrill MyClip and treated his MR. You can see so the MR reduced significantly after clip. You can see this is the MR before clip, and the MR after clip significantly reduced. And this is another patient who is an 81-year-old male who is a patient with multiple comorbidities, and we did echo. Echo showed papillary muscle rupture with prolapse. So he, since considering his age and high risk of surgery and high surgical risk, multiple comorbidities, we again went ahead and decided to do a clip. So post-clip, the gradients were fine and the MR reduced significantly. So you can see the clip being deployed successfully. All the 3 patients were discharged on day 3, and they had significant improvement in the quality of life and congestive symptoms. Clip can also be used as a bridge to transplant. It can be used in high-risk patients with acute MI, in MR and papillary muscle ruptures, in both atrial and ventricular secondary MRs. It can also be used in patients with mitral valve repair with ring annuloplasty. So when we see patients with secondary MR, usually we go wrong thinking that the guideline-directed medical treatment will fix, and we always have this tendency to wait longer. But the co-opt evidence clearly says there is 47% reduction in heart failure hospitalizations on GDMT. And sometimes we say EF is too low, too risky. But the expand criteria, it's a registry data which says that even though the EF is less than 20%, offering this therapy to a right patient probably reduce the heart failure by 74%. So the threshold can be lowered. So when to take a secondary MR patient to TIER? So first, see if all the gate criteria has been met, whether the patient has been optimally treated with medications. Even after optimal medication, if he still remains to have MR3+, and if the LVEF is more than 20 and the life expectancy is more than 12, and if the anatomy is favorable, consider So it is very essential that you identify the sweet spot. So any patient with MR3+ and ejection fraction 20 to 50, no irreversible LV damage, and if the effective regurgitant orifice area is disproportionate, consider MR, consider MT. So MR also can be used as a bridge to transplant. We can see the data from MITRA bridge data, and basically there are many RCTs which have validated the efficacy of this therapy. So you should always have a low threshold to consider this therapy, and its timing, which is very important. And the trans-esophageal echo is your endpoint, and it can be used as a bridge to transplant. So generally, in our practice, we miss a lot of mitral regurgitations, and especially in elderly patients, thinking that it's just age, COPD. So most of the times, the murmurs are either faint or silent, and the symptoms are not classical, and echo access is limited. So be proactive with echo, and whenever you see patients with MR in moderate category, try to evaluate them in detail so that you can identify the right pathology and offer them the treatment. Thank you for giving me this opportunity.
Any questions or comments? I think if there are no questions, we'll proceed further. We're running slightly behind the schedule. Now we'll go to the last session of this Upgradio, the newer interventions. It's a very interesting things we'll discuss on something new happening in interventional cardiology front. We have a real game changer, I would say, is low contrast or zero contrast PCI, which all of you might need it in the day-to-day practice. Renal denervation is again fast coming up, and for our resistant hypertension patients, we'll give a brief idea and a brief exposure what we had, and then we'll also discuss.
Thank you, Dr. Rahul, for this wonderful session. It's time to felicitate. I request sir to please come on the stage to felicitate Dr. Rahul. Dr. Srinivas, sir. Sir. Thank you, sir, for this wonderful talk. So let's move to the next part, that is newer innovation or interventions. For this, we are having chairpersons. We are having two chairpersons for this, Dr. Syed Imamuddin, sir, and Dr. John Christopher. So, do we have an introduction slide of Dr. Syed Imauddin? Yeah. So, Dr. Syed Imamuddin, he is a professor and HOD of cardiology at Osmania Medical College and Osmania General Hospital, Hyderabad. He is a senior interventional cardiologist with 28 plus years of experience, performed over 21,000 cardiac procedures, best cardiologist of Telangana 2023 and 2021. Guinness World Record for largest men's health awareness event 2018, multiple national awards including Vaidya Ratna, Vaidya Shri Pratibha Puraskar and Visishta Puraskar. Recently been awarded with FACC fellowship by American College of Cardiology, Washington DC, USA. Many awards and recognitions, having membership of HFS, CSI, IMA, made a lot of presentations in various conferences and having many publications. I request Dr. Srinivas to please felicitate Dr. Syed Imamuddin with the bouquet and shawl and memento. Thank you, sir, for giving us time and coming yesterday and today also. After this, we are having second chairperson for this, Dr. John Christopher. Can we have introduction slide of Dr. John? Yeah. Dr. John Christopher, he is a senior consultant interventional cardiologist. 30 plus years of experience. He is currently associated with Care Hospital as a senior consultant interventional cardiologist. Sir, please remain on the, you have to felicitate Dr. John also. Then also served as registrar in internal medicine at Christian Medical College, Ludhiana, registrar in cardiology care hospitals, Hyderabad, and director of cardiac imaging. He has additionally contributed as imaging subspecialty coordinator at the national level for the Cardiology Society of India. Known for his expertise in interventional cardiology and advanced cardiac imaging, he has authored numerous national and international publications and received several prestigious awards in the field of cardiology. Sir, if you can please, you are also chairperson for this session. Now let's move to the session. So we have Dr. Prashant Pawar. He is going to talk on newer methods of pacing, bundle branch pacing, leadless pacing. Dr. Prashant Pawar, he is a consultant interventional cardiologist from Mumbai. He is a renowned cardiologist with 9 years of experience. He has completed DNB in cardiology and has developed expertise in complex coronary interventions and transradial angioplasty procedures. His special interests include complex angioplasty, coronary imaging, chronic total occlusion interventions, and heart failure management. He is trained in implantations of pacemakers and cardiac resynchronization therapy devices and has extensive experience in advanced cardiac care. Well trained in advanced echocardiography, including contrast echocardiography and speckle tracking imaging. Author of several scientific papers and presenter at multiple national and international cardiology conferences, has actively participated in conducting workshops, seminars, and educational program in the field of cardiology, recognized for his contribution to interventional cardiology, cardiovascular imaging, and heart failure management. So I would like to hand over the dais to Dr. Prashant Pawar. Yes, sir, over to you.
Good afternoon, all of you. I thanks the organizer for the platform. Coming to my talk, which is newer methods of pacing, the bundle branch pacing and the leadless pacing. So we all have seen the evolution of pacemaker, right? From the bulky, like a battery pack devices to a single chamber pacing, then the dual chamber, and since 2016, we are with this leadless pacemakers. And initially, which were single chamber, now the atrial sense dual chamber pacing of leadless type. Now, issues with the pacemakers were, one was the leads were the weakest part, where issues of lead related complications, infection, hematomas, lead fractures, and endocarditis, Second was the mechanical issue of tricuspid regurgitation, the pulse generator pocket related issues of hematoma, infections. So we all have seen these complications, and they are noted also almost to a tune of 7 to 12%. The most common presentation usually is this pulse generated related erosions and the pocket hematomas, which keep on occurring again and again. Most of the time patient comes with the infections of the pocket, we remove the device, we put some temporary pacemaker, after few weeks we again implant at other side, again that gets infected either because of infection or maybe because of some allergic reactions. These are the patients which really troubles a lot. So the leadless pacemaker initially of NanoStim, then the Micra device came of Medtronic and the AVR from the Abbott. Not going in detail of each and every variant, but few things what we require to know is Micra comes as two types. One is the Micra AV and the Micra VR, out of which both the devices are almost same except the accelerometer based atrial sensing is present in the Micra AV, which is not in the Micra VR. So it's like a acts like a dual chamber pacemaker. So if you see the basic things, one, this Micra device will have a tines, which are nitinol tines, that helps to adhere the leadless pacemaker. The distance between this tine and the cathode is at the tip of the Micra device, is almost 1.8 mm. And the distance between the two anode and cathode is 9 mm. So total it comes to around 10.8 mm. Why this is important? Because while placing the leadless pacemaker, we should know the thickness of the interventricular septum, and accordingly from the distance on a fluoroscopy, the anode, we can measure, we can understand how far we have gone in the septum. Abbott has a different AVR device. The difference is that it has this fixed helix structure, where nitinol tines were in this Micra. Here this will have a fixed helix structure. So what are the benefits of this leadless pacemaker? One is it minimizes the infection risk. It's a less invasive procedure. Lower complication rates are there. Lead related complications are less, as well as the lead related activity restriction. Most of the time we have seen frozen shoulders and all because of immobility. Less hardware in the body. Nowadays people go for all these cosmetic things, especially young females. The reduced procedure time, and most important abroad or in UK, why it moved more is because of the faster recovery and the less hospitalization. There in UK, if you see, the hospitalization cost is too high. So 4 to 5 days post procedure hospitalization, the huge burden on the healthcare. So in our setup, what we do is that once we implant the leadless pacemaker, we usually discharge the patient second day morning. So within 24 hours. The disadvantage of leadless pacemakers in the initial phase of the career, the issue is with this possibility of the device dislodgement or the pericardial effusion. Initial, those catheters, the sheaths were very sturdy, they were very strong, that causes this pericardial effusion. Implantation attempts initially were aborted because of the anatomical problems like scoliosis, or issues like IVC filters, or there's acute angle, 90-degree angle between the IVC and the right atrial junction. But nowadays we do this carotid, the jugular leadless pacings. So that is not a contraindication now. We can't do conduction system pacing with these leadless pacemakers, because these leadless pacemakers have to be in this trabeculated part. It has to be in the lower septum. We can't go it higher septum. The pacing induced cardiomyopathy remains the same. Battery longevity in a leadless pacemaker roughly lasts around 12 to 13 years, but not even a decade has completed for the leadless pacemaker, so we don't know the long-term data yet. Remote monitoring device is not possible with leadless pacemaker, and long-term data is not there. Cost is a major concern in our country, where 10.5 to 11 lakhs is a huge amount. So when to select these patients for this leadless pacemakers? When the transvenous pacing is not possible, either because of limited upper extremity venous access, or if there is a high risk of infection, pneumothorax, or patients on hemodialysis where you want to preserve the venous access for those AV fistulas, or patient who have a atrial fibrillation with a slow ventricular rate. As such, you are going to give only a VVI pacemaker, single chamber. So why not to go for this leadless pacemaker? Or patients with a AV block or low anticipated ventricular pacing ratio, in those cases leadless pacemaker becomes a good option. Now coming to the instruments, we have an introducer and a dilator and the Micra delivery system. The sheaths are almost 23 French inner diameter. So you have this hydrophilic coating sheath 23 French inner diameter. Access is through the right femoral vein. Nowadays, dictum, as we saw yesterday's lecture, everything is sonography guided. Even the venous punches, we should try for this sono guided punches. Safety is a must. So once we puncture the femoral vein, pass a 6 French free sheath, put a Teflon wire, put a JR catheter, exchange it to a Amplat's guide wire, You require stiffer wires. Why? Because the sheaths are very sturdy, especially these patients are very frail and sometimes scoliosis is there, a lot of calcification is there, you may end up tearing the vein. So the sheath of this device has to reach the superior vena cava. For closure of this sheaths usually is not an issue because these are venous punctures. You don't require per-close device and all. Good compression or maybe a figure of 8 bandage suture does well. Only you have to remember before discharge you remove that suture. So one I said one is the sono-guided puncture, placing a long guide wire, put a dilator sheath, remove the dilator. Now is this delivery catheter introduction. So you have this dedicated catheter which comes from Micra. It has 3 buttons on it. The blue button is for releasing, for advancing the device. There is a gray color button which is a deflection button. So in the initial phases, what all complication occurs is because of erroneously too hard deflecting. This is very sensitive button. If you minimal 1 mm also deflection, it deflects rapidly, Third is this lock. So once we pass the sheath, we pass the catheter, you remove let the sheath come down to the IVC. Once the sheath comes to the IVC, automatically this catheter drops down to the septa. Just like the way we do BMV, we do the same thing. So same way it will drop on to the septum. Do anti-clockwise so as to enter the tricuspid valve, advance the catheter, deflecting. Then do a clockwise so as to reach the septum. So once we see how to implant, so one is the RAO view, we divide it in the 9 chambers. The second chamber, the lower chamber, septal, is the area of what we need to target. So how it looks like a goose neck, it looks like a goose neck. So sheath is down, then you have this Micra delivery catheter and the Micra pacing capsule is there in this delivery sheath. Once we have achieved the location, you have to remove that lock, you have to release the tether. And then what I said, that blue is this delivery. So once we pull it back, once we push and pull it back, it will act like a bullet, it will deliver the Micra device. This Micra has 4 tines, nitinol tines. So it will go in and it will get adhered to this chordae tendineae and in the trabeculation. So then we do this tuck test where there are 2 threads at the back of the catheter where we pull those threads. So there will be a little movement which each contraction and relaxation of the ventricle, that's called as a tuck test. When we see that the device is well fitted in, then what we do is we cut the thread and slowly we pull from the other end, the other thread, and it comes out. That's how the device is released. In few cases where anatomical issues are there, we do this jugular access where the sheath is a smaller sheath and it becomes very easy with jugular because directly it sees the septum and the inferior. Now retrieval catheters, as such dedicated catheters are not available, but sometimes we may have to remove these devices. So tri-loop snare are easily available with us and the success rates are very good with this tri-loop snare. So how to select a patient? Suppose you have a patient with a sinus node dysfunction. If the ejection fraction is between 40 to 50 and his ventricular pacing requirement is more than 40%. So if the ventricular pacing is more than 40%, you go with a transvenous with a left bundle branch pacing. Don't go for this leadless pacemakers. If your ventricular pacing requirement is below 40%, these are the patients for leadless pacemakers. For any leadless pacemaker, you should have some P wave. If there is no P wave, that means those patients are not indicators for leadless pacemakers. Those patients who require atrial pacing, they require a transvenous pacing with a left bundle branch pacemakers. Permanent AF, again, they are good candidates for leadless pacemakers. Coming to patients with AV block who have a EF of 40 to 50%, they again are good candidates for transvenous pacing with a left bundle branch pacing. So the disadvantage of leadless pacemakers in the initial phase of the thing, it requires a learning curve. so possibility of device dislodgement, but we can easily retrieve the device back also. Pericardial effusion, the risk is almost less than 1%. With the newer sheaths available, the pericardial effusion rates have come down. Because of this anatomical issues, jugular access is possible, so that is not a contraindication now. The conduction system pacing is not possible with this leadless pacemakers. Pacing-induced cardiomyopathy remains a problem. Battery longevity is 12 to 13 years, but we don't have a long-term data for that. Remote monitoring is not possible with leadless pacemakers, and cost is a major factor, especially in our country, where it's almost 10.5 to 11 lakhs. So Western countries have all gone for this leadless pacemakers. We Indians, we have more approach for this newer methods of pacing, that is the conduction system pacing. So now why this conduction system pacing is required? If you see this initial single chamber pacing, the right ventricular lead, when we pace the RV lead, it causes a LBBB, and because of which it's a non-physiological pacing. So imagine a left ventricle will contract, at the same time the septal will relax, or septum will contract, the left ventricular free wall will relax. Here, because of this non-physiological pacing problem occurs, there occurs a dysynchrony, and that leads to worsening of the ventricular function. So what happens with the RV apical pacing? One is there is a electrical dysynchrony. Second, there is a mechanical dysynchrony. This all will lead to the LV dilatation, LV strain, LV fibrosis. Because of all this problem, there occurs heart failure, and same thing occurs with the left atrial, and because of which high chances of atrial fibrillation. If we see the conventional pacing, biventricular pacing, and if we compare to the physiological pacing, that is conduction system pacing, the risk of VTVF was almost 9% in biventricular pacing, whereas it's only 4.5% with the physiological pacing. So that's almost 50% reduction in the ventricular fibrillation and ventricular tachycardias. Coming to the new onset atrial fibrillation, almost 65% reduction of new onset atrial fibrillation with the physiological pacing is there. That's the advantage of physiological pacing. So conventional RV apical pacing will cause all this myofibrillar disarrays. There occurs asynchronous cardiac contractions, negative inotropy, and this all leads to this recurrent hospitalizations, heart failures, and atrial fibrillation. So then came this dual chamber pacemakers, where the atrial and ventricular dysynchrony was taken care of, but the ventricular to ventricular dysynchrony was still remaining. So that's why the problem occurs, and hence this His bundle pacing came as a concept. So His bundle, it gives two, left and right. Left will have three things, anterior, septal, and posterior. So why not to pace the His bundle when you have a conduction system abnormalities? So in EP, we do certain electrograms. So in this EEG, what we get is, in the His electrogram, so what we get, AH and HV interval. AH indicates something in the AV node. So normally the AH interval is below 120 milliseconds. HV is something where is because of the conduction system. So normal HV should be below 55 milliseconds. So if the HV intervals are prolonged, that means the problem is in the conduction system, and they require conduction system pacing. So those are the ideal candidates for CS pacing. So key factors for this physiological pacing, one is selection of the right patient, right tool, a simple technique, simple algorithm for capture confirmation, and a right strategy for follow-up. So can all pacemaker implantation be a conduction system pacing? Yes. Ideally, this physiological pacing gives a better benefits, you know. So I feel after past few years of CS pacing, patients, only one indication I'll say which requires RV apical pacing is patients who require ICD. Those are the only one indication for RV apical pacing. Otherwise, all should be for the physiological pacemakers. So patient who need committed ventricular pacing, or as an alternative for CRT, especially in our country where cost is an issue, rather than going for CRTP and all, why not to give for a physiological pacing with a biventricular pacemaker, dual chamber pacemaker, or a non-ischemic cardiomyopathies, or a wide QRS with a prolonged HV interval, or ischemic cardiomyopathies with a low scar burden. These are ideal cases for CS pacing. Or patients who have a pacing-induced cardiomyopathy in the initial few months to years, or AV junction ablations. So choosing the right tools where we have special delivery catheters. So one, universally what we use is the C315 His fixed curve catheter, and we have certain pacing leads which are lumenless lead, is 3830 select secure, which is a lumenless fixed lead, these are very thin leads. So even if it perforates also, even if it perforates the septum, goes to the LV, usually nothing happens. These are very thin leads. So the predictors of loss of capture was almost 12% and all are related to the lead design. That was the main concern. So which is the target site? So how to determine a target site? Every one of us may not be having a EP system in their cath lab. So one easy way is fluoroscopy guided, where we pass a quadripolar catheter in the his, usually it goes in the near the his bundle. We pass a normal RV pacing catheter in the right ventricle apex. The curve, the tip of the curve of the right ventricle apex, where it touches the his catheter, that usually is the area where the his bundle is there. And if you go 1 to 1.5 centimeter below, you will reach a left bundle branch. So that is the area what we need to target for pacing the left bundle. The Chinese are very innovators. In RAO 30 degree, below the tricuspid, we divide it in the 9 quadrants. So the second quadrant is the area where usually the his bundle is there. And the fifth area is there where the left bundle branch is there. So these two, easily we can do it in our labs where even the EP system is not available. We don't require actually a dedicated EP system, but what we require is a 12 lead ECG while doing this. So how we can do it? Usually those pulse system analyzers, usually the company people are there, that can be used for this, or ECG monitors, or even a treadmill test monitor can be used where we increase the sweep speed. Only thing is that we should not use our routine leads. We have to use the needle leads available so that the view is not obscured. Now, third very important way of LBB pacing is this PVC guided. Dr. Shanmugh Sundaram from Velama Medical College, a very beautiful paper from him is how a PVC guided can be used for pacing, you know. So what to do in this, you require 2 operators. One, here you have to have a rapid pacing. So your lead should be completely dry. You should have a powdered gloves. One operator should be rapidly twisting the lead. Second operator should keep a watch on the V1. Normally you will get a QS pattern in the V1. When rapidly you will rotate the lead, once you get a PVC and your morphology changes from QS to QR, that is the area where you pace the left bundle, and there you have to stop. So that's a very good landmark how to pace LBB from a PVC guided. That's called as a template beat pattern. So this template beat pattern confirms minimal myocardial injury and avoids the septal perforation. Complications, what can happen with this is the septal perforation. So how to identify a septal perforation? Once your impedance drops below 450 ohms, or suddenly the current of injury was there, suddenly you lose a current of injury. That is the area where you have perforated the septum. You know, usually don't get panicked with this lead. These leads are very thin leads. You just untwist the lead and then again seek a new spot and just fix it. Coming the simple algorithm for capture, what I said was in V1, once you get a QR pattern, that is the RBB delay. So that is a major criteria for LBB capture. Other criteria are there where demonstration of left bundle potential, or we have certain things called as a left ventricular acceleration time. When there is a shortening of left ventricular acceleration time, or there is a septal capture, these are the minor criteria. So the advantage of this conduction system pacing, one, you get a cosmetic ECG, you get a narrow QRS, your synchrony is maintained well. Second, your electrical resynchronization occurs immediately after left bundle branch pacing. You know, in this CARTO system, what we do during electrophysiology, where immediately you will get a electrical resynchronization. Third main important is the mechanical resynchronization. What happens because of annular dilatation, there occurs a mitral regurgitation. Moment you do this left bundle branch pacing, that MR also reduces, your LV size also reduces. And the fourth important, it can be a very good way of cost-effective cardiac resynchronization therapy, especially when patients can't afford 7-8 lakhs of device. A dual chamber pacemaker with a left bundle branch pacing does a very good one. Second is a cost-effective CRTD. A dual chamber ICD, when the one lead is pacing the left bundle branch, that is a very good cost-effective way of CRTD. So these are the advantages of conduction system pacing. Few cautions. One is it came in 2017, so not even a decade has over, so we don't know the long-term data. These leads are deep-seated, so myocardial contraction-induced lead damage we still don't know. Potential complication we have to see where the lead dislodgement in the LV, where it can cause embolus and that may cause a stroke, we have to find out. Lead extraction, if required, that is still unanswerable. So these are the few unanswered questions. Probably in few years we may come to know. Thank you.
Any question? I just have a question in a patient with LBBB cardiomyopathy with scar. So what we have seen is that on the MRI, if there is scar in the posterolateral wall, he's a great candidate for substrate pacing. But on the other hand, if the scar is more in the septum, then you can use the conventional CRT.
Yes.
So that's one thing we use to differentiate apart from the other things that you have said.
Absolutely.
So that's just a comment. If there are any other questions, otherwise we'll have the next speaker.
Thank you.
Thank you. Thank you very much for the nice talk.
It's time to felicitate. I request our chairperson to please felicitate Dr. Pawar. John sir, please come forward. Sir, please come at center. After this, we are having next session, zero or ultra low contrast PCI. For this, we are having Dr. PLN Kapardi. Do we have introduction slide? Yeah. So Dr. PLN Kapardi, he is a senior interventional cardiologist and the clinical director, Cath Lab Care Hospital in Banjara Hills, Hyderabad. He is having 38 plus years of experience. He is senior interventional cardiologist and the clinical director of Cath Lab, and specialized in complex coronary interventions, transradial interventions, chronic total occlusion interventions, and IVUS guided procedures. Over to you, sir.
Thank you, Kaparthi, for your time and agreeing to speak on this interesting, important aspect. I really feel all of us should believe this, and it is a real game changer in our coronary interventions. Previously, we always used to think the contrast is a big problem, rising creatinine is a problem. Now, actually, we have done procedures with a baseline angiogram in view, and with most of the times IVUS guidance, only a few last 5 cc of contrast to document. And here, such procedures can be done safely. Please believe in it and probably follow it, and you'll do good to a lot of patients. Another misconception was a lot of patients used to be sent for CABG thinking that it's more safe. Actually, it's more worse. The chance of patients worsening creatinine and patient going into dialysis is more worse with CABG than with our zero contrast or low contrast PCI. I think Kaparthi is a specialist in interventional cardiology and CTOs also. They get exposure to IVUS, and we requested him to deliver this talk. Over to you, Kaparthi. Thank you.
Thank you, Dr. Srinivas. At the outset, I am thankful to Lupin Industry and Dr. Srinivas Kumar for giving this opportunity. Like yesterday topics like angiogram as well as the tools, the contrast usage is also very, very important, because all of us having a habit of puffing, but first we should avoid that puffing, very important. And there is no concept of zero, because medical legal purpose we have to document the relief of the stenosis also. So practically there is no zero contrast, but there is ultra low contrast PCI, the terminology more important. We should make the habit of doing things, and with the scientific evidence today subsequently I am telling I am speaking regarding the subsequent slides regarding the importance, especially after imaging, intravascular imaging, both IVUS as well as saline OCT totally revolutionized and strengthened the concept of this ultra low contrast PCI, especially in some subgroups, high risk subgroups, which I will describe. So as we know, contrast is a renal toxin we give to cardiac patients. Almost 1 in 10 PCI patients develop contrast into AKI, acute kidney injury. And as we know, chronic kidney disease and heart failure and elderly people as well as diabetes, all these are the high risk subgroups are developing this contrast nephropathy. And of course, acute kidney injury after angioplasty linked to worse in hospital long-term outcomes, and especially both bleeding requiring blood transfusions and acute kidney injury are the major determinants of the outcomes of the angioplasty. As we know, the Mehran risk score is the key drivers of contrast in nephropathy, hypotension, IABP usage, and heart failure of NYH 3 and 4, and elderly population more than 75, anemia, diabetes, EGFR less than 60, and high contrast form. All these are risk factors of developing contrast in nephropathy. As we know, the intracoronary imaging now shifted to class 1 indication. Yesterday, beautifully described by Manjappa regarding the OCT intravascular ultrasound, and it is aligned with the guidelines, intravascular imaging. And what is ultra low contrast PCI? So most important definition is the ratio of contrast volume to EGFR should be less than 1. So almost 0 to 10 ml of total contrast for the procedure, essentially eliminating the contrast acute injury. So these are the important things which we can do during the procedure. One is IVUS physiology co-registration, that is called dry registration, co-registration rather than the contrast-induced co-registration. And angiographic road mapping is important. We should make that habit of contrast angiographic road mapping. A single stored contrast frame used as a fluoroscopic reference overlay. And very important is marking wires and wire tree, that is a metallic silhouette that is called, because the wires we have to do the main vessel as well as the branches, so that they will act as a framework, so that without contrast we can do the length of the lesion, as well as we can where the working place of balloons and stents we can assess. And of course the IVUS sizing and stent optimization you can do with the help of the imaging. Who benefits from this strategy? Most important is stage 3B5 chronic kidney disease patients, especially EGFR less than 50, high Maharan risk score patients, especially CHF, anemia, diabetes, hypertension and advanced age, and chronic total occlusion where the long procedures with historically high cumulative contrast exposure, and of course complex angioplasty, left main complex lesions and bifurcation lesions. And as we know, the acute kidney injury risk is very, very high if the Maharan risk score is more than 16, almost to the tune of 57%. And if it is 0 to 5 Maharan score, it is 7.5%. So this is most important. Whenever a person comes with the chronic kidney disease, we have to assess, and along with the other risk factor scores. And step by step how we can do. The first and foremost is a roadmap, the angiogram. So already we have diagnostic angiogram. First you make a roadmap with a low volume injection, and wire the vessel, that is a metallic frame or metallic silhouette you have to do, and pre-PCI IVUS pullback you have to do, and of course fluoroscopic markers are there. Sometimes, especially if the calcium is there, you can use the calcium silhouette as a boost by putting a balloon, and of course then subsequently our job made finish we can easily with the balloon and stent deployment, and post PCI IVUS optimization we can do. And what are the IVUS criteria? Yesterday beautifully described by Manjappa. The minimum stent area is the ultimate determining factor for the long-term outcomes. Of course, stent expansion, stent apposition, and edge dissections, and the reference segment disease, and mechanism of complications. All these we can assess by means of intravascular imaging. So not only it is useful as a part of ultra low contrast, but vascular related, coronary related, all angioplasty related things we can assess. And why it matters? Outcomes that follow the evidence. Most important is the maze risk. IVUS versus angiographic, automatically the IVUS guided, the risk is very low. So ultra low contrast protocols reduce the contrast volume by EGFR ratio less than 1, which is standard compared to the angiographic at PCA. And almost ultra low contrast angioplasty reduce the incidence of AKI, and benefit consistent in CTO angioplasty where the procedure length historically will draw the highest cumulative contrast loads. And these are the perils which pitfalls of the table. And what are the favorable factors for ultra low contrast is builds a coronary wire tree, that is a metallic silhouette, and use one stored roadmap angiogram report with the same workhorse view, that is called, as Dr. Srinivas told beautifully, the elongated view where the lesion you can see that workhorse we have to go like a workhorse wire, and co-register IVUS with physiology, that is a dry co-registration, and reserve the remaining contrast for a brief final check, that is it is not zero. Final we have to show the result to the patient. And of course another important addition is hydration. The only saline hydration is the one which will prevent the contrast related kidney injury, which is scientifically described. So saline hydration and use of transradial access to further lower the AKI risk in high risk patients. Of course, especially the feasibility is less in patients with heavily calcified, severely tortuous vessels, which limit the pure landmark based navigation. And of course, the steep learning curve and arterial lesions and severe overlap can still need targeted low volume injection, not a substitute for physiological assessment. And emergency conversion for standard angiography must always remain available because this is patient-centric and safety. Whenever complications, don't stick on to ultra-low contrast. You take the contrast and identify the complications. And IVUS guide ultra-low contrast PSA, the bottom line is it is a class 1 evidence, image guided, and low contrast volume, so we prevent the AKI, and kidney protective by means of design, and best for the highest risk patients like left main, as well as complex lesion subsets and elderly population with the faint patients and highest Maharan risk score patients. And this is another device recently came, that is a assist controlled volume injector which we use. So especially it increases safety up to 30% reduction of the contrast in acute kidney injury we can compare to the manual injection, and 35 to 45% reduction in contrast use without any compromising image quality when comparing to 4 French and 6 French diagnostic procedures, and increase the workplace safety up to 50% reduction of the radiation exposure. And of course the injector manually, when sometimes any musculoskeletal problem of hand, we can minimize for the assistant and increase the operational efficiency. So this is the diagram of the instrument of the assist control volume injector. It is an advanced technology physician staff can rely on for consistency and safety, and standardized constant injection for all interventional diagnostic angio procedures, from small injections in the coronary arteries to large volumes in the ventricles and peripheral vasculature. It is a versatile tool. And with this background, just I want to present one case. A patient presenting with unstable angina with risk factors of diabetes and hypertension, having mild LV dysfunction, and he underwent bypass surgery in 2019, and post angiogram edema is patent, SVG to PDA occluded in 2022, it is native TBD, post PDCA to RCA 2022, and presently he had a native TBD with SVG to PDA occluded, LMC osteal tight lesions, patent stent in RCA. So his creatinine is 2.8, so calculated EGFR is 30 to indicate a severe CKD, and plan is ultra low contrast IVUS guided angioplasty. So this is the one you can see the tight osteal lesion, and intravascular imaging was done, which is showing both the size of the left main as well as the tightness of lesion and plaque load at the ostium, because the OCT is not suitable for osteal left mains. And pre-dilatation was when 3 into 12 NC balloon, and subsequently 4 into 9 millimeter DES deposition from beyond the ostium to distal left main, and then subsequently hyperdilatation was done with 4.5 to 6 millimeters NC balloon at 20 atmospheres. And post-stent IVUS, it was shown a good position as well as expansion. Subsequently, still hyperdilatation 5 mm, it is still ostium, some anapposition is there, and this is the final result. And case 2 is a middle-aged patient present with unstable angina, having good LV function. Patient has osteal RCA tight lesion with a serum creatinine of 3.2, and calculated EGFR is 28 ml per minute per 1.5 square meters. This is osteal RCA. By means of flotation technique, we wired, and then subsequently, after identification, pre-dilatation with 2 into 12 millimeter balloon was done, taking calcium as a landmark, and IVUS was done, showing more than 270 degrees calcium arch with a minimum luminal area of 2.66 square millimeter. And here we did the intravascular lithotripsy was done because of the heavy calcium, 3 into 12 millimeter with the 3 cycles, almost 30 pulses. And then subsequently we positioned 3.12 DES, and then post-stent IVUS minimum stent area is 8.3 square meters, indicating adequate luminal diameter, and this is the final result. So as we know, the conclusion is a class 1 evidence, low incidence of kidney injury, and best for highest risk patients. This in intravascular imaging angioplasty. And then subsequently, just a brief 2-3 slides regarding saline OCT. Saline OCT is an important part of the ultra low contrast angioplasty, and as we know, intravascular imaging class 1 with a good resolution, 10 to 20 microns resolution. One simple swab opens the door, and one flush swab contrast clears the blood. Saline does the same job. smart systems help, sometimes you have to take. And almost 87% of saline OCT pullbacks for clinically acceptable for PCI decision making. So measurements that match, reliable across the presentation, and a growing body of the support. So it is backed up by recent guidelines. It is aligning with the guidelines class 1 indication. So why teams are adopting saline OCT is zero iodinated load, expands eligibility, diagnostic confidence, fits existing workflow, complements contrast, safe track record. And 4 steps important during saline OCT is engage and virage. And then 20 ml or 50 ml syringe you can take for a good displacement of the blood, and flush and capture and optimize and proceed. And who gains the most from saline OCT? Chronic kidney disease patients, heavy contrast load, already it is used for staged multivessel angioplasty patients for repeat procedures in the same admission, left main and complex lesions patients, and contrast efforts patients, that is allergic reactions. And of course, expanding the eligible pool, that is saline OCT is nowadays option because of the growing elderly population, diabetic patients, where acute kidney injury is more. So simple habits for extended saline OCT is go deep and coaxial with the coronaries is more important with guiding catheter. Trust the pump, and sometimes let automation sometimes triggers, mix and match, build the repetition, combine with ultra low contrast PCI. And saline OCT, these are the things, it is evidence based class 1 indication which is kidney safe. You have to make the guideline aligned, that is important, and practice, you have to regularly practice so that we can go to ultra low contrast angioplasty in our day-to-day practice. You have to make the habit. So where intracorneal OCT is nowadays Ultrion 3, that is almost AI automated one, and 1 second AI pullback, automated plaque characterization run, and it is purely saline OCT. So that is nowadays still it is coming, not yet come to India. And with this background, I want to present one case of 76 years male having risk factors of hyperdiabetes, underwent bypass surgery in 2008. He underwent angioplasty in 2019. Presently presented with acute kidney syndrome of NSTEMI with troponin I positive with moderate LV dysfunction. His creatinine is 1.3, calculated EGFR is 68. He had occluded lima to LAD, patent OM graft. Strategy is PCI to LAD ISR with saline OCT, that is as a part of ultra low contrast angioplasty strategy. So this you can do the RAO caudal view of left coronary showing the intermediate lesion in circumflex and a tight ISR of the proximal LAD, and RC is dominant, and it is a distally diffuse disease. And as we were pre-dilated with 2.1 to 12 at 20 atmospheres was done in the lesion segment, and followed by, because of ISR, we did the cutting balloon 2.7 to 12. And subsequently we did the saline OCT, and then with very good images you can see. And the analysis of the OCT showing almost a luminal gain of 3.1 square millimeters to 3.4 square millimeters with a good cuts across the neointimal hyperplastic segment of the plaque. And then subsequently deployed a 3.5 to 15 giant sky point with an overlap of the previous stent from ostium of the LAD. And then we again we did the saline OCT post DES with a good clarity we got. With a good resolution, the expansion is 91%, that means adequate, more than 85% is adequate. With a minimal stent area is 4.5 square millimeters, which is a good thing, because more than 4.2 means a long-term outcomes are good in the stent patency rates. So OCT analysis showing almost the luminal gain improved from 7.2 at the ostium of 8.4 square millimeter. That means indicates a good stent expansion as well as opposition. So this is the final result. So saline OCT ready to make a difference today because it is a guideline aligned, which is class 1 indication. Evidence back is there. 87% of clinically acceptable images we will get with a saline OCT, and it is a kidney safe, and we have to practice routinely. And with this, we are conducting a calcium intervention imaging November 27th to 29th. Invitation to everybody. Thank you.
I think how many of you sitting here are exposed to this concept of low contrast PCI? I think all of you are, it's good Because it's true, it has come to clinical practice. That's why I make it a point to mention this in any meetings. Any questions or comments?
I want to do one expression because we have a habit of doing puffing. First, we should avoid that
Yeah,
one.
that's
That is number one. And we have to adopt these low contrast, ultra low contrast for patient safety. Another important point: whenever we are planned for ultra low contrast, you have to keep the frame rate high, so that your films should be more without any streaming effect, and you should have a good angiographic resolution for decision making.
Thank you.
Yeah, thank you, sir, for this wonderful talk. I request all our chairperson to please felicitate sir with bouquet, shawl, and memento. Now let's move to the next part, that is renal denervation, present data, case selection, and procedural tips. For this, we are having Dr. Ramakrishna Janpati. Do we have introduction slide? Yeah, Dr. Ramakrishna Janpati, he is an interventional cardiologist, active faculty speaker at national and international cardiology conference with multiple academic publications. Experienced interventional cardiologist with over 10 years of experience. Faculty speaker for TCT San Francisco, Euro PCR, Paris, NIC, CSI, then India Live and TCT India. Multiple peer-reviewed publication in Indian Heart Journal, Cardiology Updates, and other leading journals. Life member of CSI, Indian Association of Cardiac Imaging, Lipid Association of India, publications. He has lot of publications in his kitty and lot of presentation he had made in various academic forums. So without taking much time, I would like to hand over the session to Dr. Ramakrishna Janapati. Yes, sir, over to you.
Very good afternoon, everyone, and thank you, Lupin, for the opportunity. And at the outset, I would thank Dr. Srinivas Kumar, who is my mentor since almost 15 years, and because of him, I am in cardiology today. So today we'll talk about RDN. This is the last presentation for this session and for the day and for the conference too. That is RDN, renal denervation, and we'll talk about case selection, current status, is there any evidence, and procedural tips in the last. So we all know that hypertension is one of the common leading risk factor for cardiovascular disease, including stroke and cardiac events. So unfortunately, only 20% of the patients will be under very good control of blood pressure, and burden is very, very high. India is not an exemption for this. We are seeing more and more young patients with uncontrolled hypertension, even with medication, maybe because of poor compliance, pediatric inertia, or real resistance or resistant hypertension. And 30% are untreated, 35% are treated but uncontrolled, but only overall 35% of the patients are under good control with medication. So we need to have some of the therapies which can increase the percentage of patients who are under control. So what are the benefits of reducing the BP? By various means, whether it may be drugs, lifestyle, or newer therapies. If you reduce the systolic blood pressure of 5 millimeters of mercury, so you will get a benefit of 10% reduction in major CVD, 10% reduction in the strokes, 10% reduction in the heart failure, and there is a 5% reduction in cardiovascular death and ischemic heart disease burden. Similarly, if you reduce 10 millimeters of mercury, the benefit is more, so that is almost 20% reduction in the major cardiovascular events. So coming to the renal denervation, this is the therapy which has gained lot of attention in 2009. So it has a turbulent course in the cardiovascular therapeutics. Initially, a lot of enthusiasm. It was thought that it was a breakthrough therapy for hypertension, but the enthusiasm fades away after one trial, that is Simplicity Hypertension 3, because it doesn't show much benefit when compared to the sham control, that is the procedure, that without any much difference in the placebo versus the real therapy. So a decade later, RDN re-emerged with stronger evidence, refined technique, and with newer clinical data. We will show you in the coming slides. The principle is same. When there is a increased sympathetic nervous system activity, it stimulates your renal sympathetic nervous system, thereby activating the renin-angiotensin system, more amount of renin-angiotensin and increased blood pressure, that is leading to vascular damage, heart damage, and kidney damage, and this cycle becomes vicious. So we want to break that cycle. So there are various methods for this. Initially, the surgical sympathectomy, so which used to be done for olden days when there is no lot of pharmacological therapies. So that was done only for malignant hypertension patient, but it is a surgical procedure, and results were short lasting because the nerves tend to regrow, and lot of patients tend to have hypotension, falls. So that's why it came out of, it went out of the picture, that is surgical. So next came the renal radiofrequency ablation. So based on this, the single electrode catheters, they want to do transcatheter, that is simple. The endovascular procedure, catheter-based therapy. Then next is ultrasound-based therapy, and newer therapies like the chemical ablation. They can inject the dehydrated alcohol into the renal arteries, and thereby leading to the ablation of the renal nerves. So coming to the trial data, that is Simplicity Hypertension trials. These are the earlier trials, that is Simplicity Hypertension 1. Even though the number of population was very small, the systolic blood pressure reduction was very significant, that is almost double digit, 14 millimeters of mercury at 1 month and 27 millimeters of mercury blood pressure reduction by 12 months in the initial trials. Similarly, the Simplicity 2, there is at 6 months, there is a 32 millimeters of reduction in the office systolic blood pressure. And next comes the Simplicity Hypertension 3 trial. This is the first in-human sham-controlled RCT, evaluating radiofrequency ablation versus the placebo therapy, that is sham control. Similar procedure, but without any actual radiation. They used to put a wire and they don't do any actual radiofrequency ablation. At 6 months, the office systolic blood pressure fall by 14 in the denervation group and 11 in the control group. There is less than 5 millimeters of H reduction, mercury reduction. So with that, everything came to negligible results because this was the first trial. So they analyzed why it happened. So there are a lot of background medication changes in both the groups, like even in the radiofrequency ablation group, even in the sham control group. So up to 40% of the patients had medication changes. So ablation was limited to main renal artery because that previous catheter was single electrode, and office BP is less reliable because most of the patients, when they walk into your office, their BP tends to go up, but here their home BP recordings will be normal, and older generation single electrode catheter could not ablate successfully for all the segments. So first, before this, we need to understand, so the procedure, we are modulating the renal sympathetic nervous system and thereby breaking the brain and kidney circuit. So this is the catheter, you can see the animation. So we will show you in the coming slides in real cases. And renal nerves, they don't concentrate at one particular place. There is a lot of interhuman variability. 60% of the kidneys had renal nerves that join distal to the main renal artery bifurcation. So if you ablate only at the ostium, so you are not actually touching the renal nerves. And more than 30% of the cadavers have highly innervated accessory renal arteries. If you do main renal artery and leave the accessory renal artery, you don't get the benefit. And renal nerve plexus often form at a distal to ostium. So that's why the newer catheters came into the picture. So with the new devices, the procedure become more standardized with greater emphasis on complete ablation extending to distal branches and accessory arteries. Ambulatory BP has become the standard for measuring the outcomes rather than simple one-time office BP, and advances in the catheter technology enabled more and uniform and circumferential energy delivery, and medication become more standardized. You should not change the medication during the procedure in the trials, and some trials are conducted on the medication and some trials are conducted even without medication also. So this is Simplicity spiral RDN catheter, that is by Medtronic. This is available in our country. It is one catheter that fits for all the sizes, 3 to 8 millimeters of renal artery diameter, easy to use plug-in and play design, non-occlusive spiral pattern, so we need not occlude the renal blood flow during the procedure, and it protects the vessel wall from thermal damage because blood is flowing. It acts as a cooling system and compatible with commonly applied device, like you can use 6 French guide and normal coronary wire. So real-time responsive algorithm automatically adjusts the power output from the catheter, and it has a circumferential because as soon as you remove the wire, it takes a spiral shape inside the renal artery, and it effectively delivers the ablation in a longitudinal and helical pattern. So these are the trial data. That is a spiral hypertension clinical program that is started in 2017. Off med, that is without medication, and on medication, and there is next trial is spiral hypertension off med pivotal trial, and the last is global Simplicity registry that is included almost more than 5,000 patients as of now, and more than 30,000 procedures were performed with this RDN catheter across the world. So if you take the spiral hypertension clinical program, sufficient evidence for efficacy, because even without medication, you can simply ablate and leave the patient on after this procedure, that is off med trials. Even on the medication, if the patient BP is not under control, you can use this therapy as an adjunct to medication, and largest data as of now and still ongoing, and it is safe too. So if you coming to the results, there is not like office BP, it's 24-hour ambulatory BP, because it reflects the true nature of the blood pressure even out of office and even in the house and during the sleep. So there is a 4 millimeters of reduction in 24-hour systolic blood pressure, and there is almost 3 millimeters of BP reduction in the diastolic, and office BP fell by almost 6.6 millimeters and diastolic by 4.4 millimeters of mercury in 24-hour ambulatory BP, unlike office BP. So it demonstrated safety and efficacy, and even at 3 months and even at 3 years. So if you follow these patients, there is a persistent reduction in systolic blood pressure, office BP, even in ambulatory BP. So absolute reduction in absolute office BP is almost 10 millimeters of mercury. On med 6 months, even at 3 years, there is a 20 millimeters of reduction in blood pressure, consistent benefits, and even global Simplicity registry, the benefits are lasting even after 3 years. So if you take the ambulatory BP chart, the upper curve, so the upper chart is like baseline, and at 3 months there is a significant reduction, even nocturnal BP and even daytime BP, there is a significant reduction in the blood pressure. Even there is no on and off effect. If you take the medication after 12 hours of off life, there is a medication will not be there in the plasma and then tend to rise the blood pressure, but this effect is consistent. There is no off effect, there is always on effect with this therapy, even with medication. So coming to the safety, it is safe, risk is 0.4% in this trial. So this is mainly vascular complication, like either it may be femoral access or due to guide manipulation at the renal arteries. So renal artery stenosis is almost zero, more than 70% renal artery stenosis is almost zero, and most of the times it is vascular complications, that is because of puncture, inappropriate puncture. So across the patient subgroups, if you take resistant hypertension, there is a 23 millimeters of reduction blood pressure, and there is office BP. And even in diabetic patient, atrial fibrillation patient, CKD, EGFR more than 40, and isolated systolic hypertension, elderly patient, prior MI, stroke. In all these patients, there is a 15 to 20 millimeters of reduction office BP. So based on the trials, it is a prospective power trials, and real world data shows there is consistent benefits even at 3 years. And nowadays it's almost the 5-year data is awaited. So newer data is going on still. So durable blood pressure reduction, it is one histopathological study. This is brown is like the nerves, renal nerves. So this is after ablation, there is no regeneration of the nerves even at day 118. That is after 6 months, there is no regeneration of the nerves. So long-term data, even at 3 years, you can see the consistent benefits, almost 20 millimeters of BP reduction in these patients. So this is one small trial based on the initial patient population, that is almost decade. Even at 10 years, there is a 10 millimeters of BP reduction, and one trial there is almost 16 millimeters of BP reduction. So this is global simplicity registry. Based on the registry data, this is almost 3-year data, there is almost 20 millimeters of BP reduction, and this trial is going on. And there is new trial, that is a spiral affinity trial is going on, and global simplicity registry is still recruiting patients. So not only radio frequency ablation, there is ultrasound based systems. So that is based on the Radiance hypertension solo trial and Radiance 2 trial, there is a 4 to 6 millimeters of systolic blood pressure reduction. So this is one single balloon based catheter that delivers 360 degrees of energy, ultrasound based energy that damages the renal sympathetic nerves. So even this is also approved. So next comes which patients suits for this. So patient preference is going to be a future indication, like if the patient wants to undergo this procedure, and in our country finances is latest the most ideal for this procedure. So in one trial there is almost 50% of the patient wants this procedure because no antihypertensive medication is needed in some of the patients, durable effect, and no risk of side effects and temporary procedure. So patient and physician recommendation, and coming to the guidelines, the societies are recommended, various societies are recommending this procedure. So now currently it is 2024 ESC and ACCHA guidelines, it becomes class 2B recommendation for patients. These are the various patient population who can benefit from this. So it's a 58-year-old male, 7-year hypertension history, uncontrolled with 4 medication, and diabetes, because he is at high risk of developing diabetic related and hypertension mediated end organ damage. So he also already had established hypertension mediated organ damage. He can definitely benefit from this therapy. And 66-year-old female with hypertension and atrial fibrillation, and 40-year-old male with glomerulonephritis, and 77-year-old with hypertension and uncontrolled diabetes and post-MI. All these patients are suitable candidates for this procedure. So uncontrolled BP, borderline control with drugs, resistant hypertension, true resistant hypertension, and unwilling to adhere, young patients and drug intolerance, and patients who are at cardiovascular risk, high risk. So uncontrolled resistant hypertension with BP more than 140 with 3 or more medication with EGFR more than 40 is an indication, and patient intolerance to medication and patient preference and global cardiovascular risk is high if these patients are suitable for these patients. So elevated cardiovascular risk, patient choice, confirmed primary hypertension, because we need to rule out secondary hypertension, rule out white coat hypertension, because I recommend this therapy based only on your office BP and timing of this procedure. So it reduces cardiovascular risk by 10%, reduces systolic blood pressure, it is safe and effective, doesn't rely solely on medication, it has always on effect. So this is some of the guidelines. If a patient is not under control with medication, you can recommend this therapy. So I will show you some case examples. Before every procedure, you need to take renal angiogram with a guide catheter and then pass coronary wire. And this is simplicity catheter. Start from the distal vessel and deliver the radio frequency. That is a small console. So you can deliver the catheter and pull back into the proximal segment. Do it in all the branches and even the proximal segment. And so do check angiogram after the procedure. So next, the other side, start from the distal area and again ablate it, cover all the segments, So this is the pulse generator, ablate all the segments. So check angiogram, and so this is the history starting from 2009 simplicity hypertension 1 and 2, then 2014 there is a dip in the procedures, and with the re-advent of catheters and new trials, that is spiral and radiance trial based on the ultrasound and radiofrequency ablation. Again, there is a increased interest in these procedures, and FDA approval in 2023, and even the US, the insurance coverage is increased, and so in future we will be seeing more and more new technologies. So there are some of the new technologies, there is alcohol mediated, there is ablative solutions, and IVUS based ultrasound systems are in development, and multi-organ denervation approach. They are targeting the both hepatic and renal sympathetic nerves. So there is a simultaneous reduction HbA1c along with 24-hour ambulatory BP. So there is future more and more metabolic syndrome patients are going to benefit from this therapy. In future we may be seeing this one as a class 1 recommendation, and it fulfills unmet need for hypertension care, and it reduces the blood pressure consistently. It has always on effect even without medication, and it is a major boost for resistant hypertension patient, and BP drop sustained up to 10 years and longer as of now, and in future we will see more and more patients who will be coming with this. Thank you.
Thank you, Dr. Ramakrishna, for covering this another interesting procedure. It will be practically, probably if the costs come down in future, it could be more utility. Previously it was actually being threatened as a competition to drug therapy. That can't happen. Drugs, pharmacotherapy is here to stay, and this can be complementary, like how lifestyle modification is one. This is a third pillar of therapy for hypertension. That's where we need to see it. The only thing is, it's an expensive third pillar. Suppose if it was cheaper, probably the benefit would be offered to more and more patients. Because competition coming up with other modalities, hope the costs will come down, and then more patients could be offered this therapy. One thing is proven beyond doubt is safety is proven beyond doubt. You need not worry on it. But the only thing is the efficacy is variable from patient to patient. That's where we are getting choked to convince patients about this therapy, because cost is high. Once they're spending more money, patients expect good control. That's where we are at this stage. But I think in future with more companies, I think the ultrasound based one is about to be launched soon in our country, and maybe we'll have more easy procedures with that too. I think with this I'll thank Ramakrishna again. And any questions or comments from co-panels or anybody in the hall? I really appreciate all of you sitting till the end, and we've come to the end of the conference. Any final questions? How many of you sitting had this system in your hospitals of renal denervation? Can you raise your hands? Very few. I think that's how, now companies have realized that we are not going to purchase the systems, but if you have a patient, they're getting the console, and also help us if you can purchase the procedure catheters, and it will be done soon. Thank you. Right.
This was the last session. Now this is the time to felicitate Dr. Ramakrishna for this wonderful talk. I request all our three chairpersons to please felicitate Dr. Ramakrishna Janapati for his wonderful talk on renal denervation. On behalf of Lupin, I am very much thankful to Dr. Srinivas Kumar, all the chairperson and all the faculties for coming here and delivering the talk. I am also thankful to all of you. Because of you only this program was possible, and in future also Lupin will bring such program for all of you PG students. Now I would request Dr. Srinivas to please give conclusion and takeaway, and then we can proceed for the lunch. Yes sir, over to you.
Thank you again for all of you for patient sitting and watching the proceedings till the end, and request all of you to have some feedbacks and tell us how to improve this program further in future. And we thank Lupin for their persistence and always their commitment for education and training, and bringing out more knowledge to all our colleagues across the country. And we thank all our faculty members and all the doctors who have participated for making this year's edition successful. Thank you. I think if there are any ways where it can be improved upon, please suggest us and we will try to inculcate those. And or any what you like, what you didn't like, all that feedback forms will be given. Please do it. And most of the proceedings will be there. Some of you are asking, I believe, faxfoundation.in. We'll upload all the videos and these things, and Lupin will also be happy to distribute them. Thank you again. Final anything, Lupin? Anybody from Lupin side? Thank you.
Yeah, all of you can proceed for lunch now. I request all spokes from Lupin to please come on the stage. I request Dr. Srinivas to please stay back so that we can have a group photograph. I request all Lupin spokesperson to please come on the stage. I request all Lupinites to please come on the stage. Lupinites. Mr. Gaurav, please come on the stage. Tulsi, please come fast. Dr. Srinivas is waiting for us. I request all the Lupinites which are standing behind, please come on the stage so that we can have a group photograph with our chair moderator and Dr. Srinivas Kumar.